12 months. And we have root resorption, in which the minimum observation period is of 1 year. So now we are following up the patient radiographically, and then we informed the patient that it is recommended to start orthodontic treatment after 1 year if the root has healed with either hard tissue or connective tissue healing. Now another case. This is a healthy 12 years old boy. As you can see from this left clinical photograph, that the patient is having an anterior crossbite in the upper right lateral incisor and lower right lateral incisors with the lower right canine. So presented for a treatment of a crossbite along with the treatment of caries. So during the dental management of the patient is presented to our clinic for management of caries. During that time, the patient presented again with a trauma. So as you can see from the picture, is the patient is having complicated crown fracture in the upper right lateral incisor. And this fracture, this trauma have been managed following the International Association of Dental Traumatology 2020. So a vital pulp therapy was performed, and fortunately the patient, they presented with the fragment, so the fragment reattached. And then we told the patient that we will not start orthodontic treatment before 3 months according to the guideline, and we will monitor for the healing and we will monitor for the formation of the hard tissue barrier. Now the last case. This is a healthy 12 years old girl presented to our clinic with a history of avulsion, and fortunately the tooth was replanted and it was supplanted and managed according to the IADT 2020. If you can notice that in the picture there is an increased overjet, an overjet of 11 millimeter, in which that the patient need an orthodontic treatment. But because the patient have suffered from a severe injury to the PDL, which is avulsion, so orthodontic treatment will not be initiated before 12 months. Now this is a summary of the observation period before commencing orthodontic treatment according to Patel and Mack 2023. As you can see, concussion, subluxation, minimum of 3 months. Lateral luxation, intrusive luxation, avulsion, minimum of 6 to 12 months according to the severity of the trauma. For the crown fracture and the crown root fracture, minimum of 3 months, and we should put in mind the healing of the soft and hard tissue. For the root fracture, minimum of 1 to 2 years, depending on the healing. Now I will discuss with you the management of traumatic dental injury during orthodontic treatment. So I will start with the soft tissue management. So if the patient presented with a fresh trauma and you see a soft tissue laceration, in addition to that, with or without loss of any bracket, it's very important to investigate about the bracket. So to take a soft tissue radiograph with a reduced exposure up to 50%. And if, as you can see here from the radiograph, if you found the bracket, so it should be removed under local anesthesia. Now moving on to management of a trauma if the patient undergoing fixed appliance therapy. So for the luxation injury, so the impact of the trauma on the fixed orthodontic appliance can be either distortion of the arch wire or the loss of a bracket. However, if the patient presented with a luxation injury, our main and our aim is to remove the traumatized tooth out of occlusion and reposition the tooth. there are different management of luxation injury. The first one is to reposition the traumatized tooth. And then we section the orthodontic arch wire. And then we use any trauma splint, for example, stainless steel or titanium, in order to splint the traumatized tooth with one adjacent tooth, mesial and distal. And then we secure the wire with either with the bracket or with elastomeric ligature or with a restoration, whether it's a glass ionomer or composite restoration. This is one of the treatment options. Another treatment option is to reposition the traumatized teeth, splint with an orthodontic arch wire. Here it is different. Here we are splinting with the orthodontic arch wire. And then we secure it similarly, either with the bracket or with the restoration or with elastomeric ligature. The last option, repositioning, splinting, stabilizing the tooth according to the IADT 2020 guideline, and then we refer to an orthodontist. So here we must inform the patient that the orthodontic treatment should be, it's recommended that to be delayed and stopped until the healing of the PDL and the soft tissue for up to 12 months. Now here an example, which is the first case that I showed you. So the patient here was unable to bite together into maximum intercuspation due to palatal displacement, as you can see from the upper right central and lateral incisor. So there are changes in the from the occlusal upper standard occlusal radiograph, as you can see. There are changes in the periodontal ligament space associated with the injured teeth. So here, as you can see, the treatment that they have provided is that they sectioned the orthodontic arch wire and they splint with a trauma splint, and then they stabilize it with a restoration. Here another case from Patel and Mack 2023. So what they have managed is that differently from the previous one, that they stabilized the injured teeth with a trauma splint and they used the orthodontic bracket. Now for the avulsion injury. So if the patient is undergoing fixed appliance therapy, it is rare to have the tooth avulsed. So because of the nature of the fixed appliance therapy, it's act like a splint. So however, the force of the impact will be transmitted along the arch wire and it will be transmitted to the adjacent teeth. It will be dissipated. However, sometimes the force is great enough in order to cause an avulsion. The management of avulsion is similar to the management of luxation. So we reimplant the avulsed tooth, we section the orthodontic arch wire, and then we splint with either a stainless steel wire, and then we secure it. Another option is similar, that we splint with the orthodontic arch wire, and then we secure it. And the last option is that we reimplant and stabilize the traumatized tooth, and then we refer to an orthodontic. For the fracture injury, as you can see that the patient presented with complicated crown fracture, and the patient fortunately is having the fragment here from the bracket slot. It can also help in the direction of the placement of the bracket. So what they have done and recommend in Patel and Mack 2022 is that providing vital pulp therapy, reattachment of the fragment, and then remove the wire and we stop the orthodontic treatment. We follow up the tooth for 3 months at least in order to see an evidence of hard tissue formation. Now moving on to patient undergoing removable functional appliance. So because of the nature of the removable functional appliance, the management will follow the IADT guidelines 2020. However, if the patient presented with a fractured component, distorted component, so we refer the patient to an orthodontist. Also, it is important to put in mind that if there are missing components, we should take a soft tissue radiograph. Now, if the patient is undergoing fixed functional appliance, so if the components are distorted, causing improper function, immediate referral to an orthodontist is recommended. Now, lastly, if the patient is undergoing a clear aligner therapy. So, because of the nature of the clear aligner therapy, we just follow the IADT guidance for the management of a trauma. So, and we should advise the patient that the orthodontic treatment will be delayed. Here, what's like the benefit of the 3D aligner, if we have the scan, so it will guide us with the replacement of the luxated or the avulsed tooth. Now, when to review the patient? So, for the luxation injuries and root fracture, first review when we remove the splint, and then 6 weeks after the removal of the splint. For the crown fracture, so the first review is within 2 weeks in order also to perform pulp vitality test.
Dr. Fatma, thank you very much. Well, I want to listen to the entire lecture, but they are forcing me to stop.
Yes.
Thank you very much for your very informative lecture. I just want to mention that the majority of the evidence used in this lecture is from Dr. Sundus al-Badri, Professor Sundus al-Badri paper, and we are so lucky to have her here today to give us a lecture. Dr. Fatma, thank you very much.
Thank you.
دكتورة فاطمة تفضلي. This way. Now we will not have time for questions, but please, if you have any questions, you can ask Dr. Fatma directly.
Okay. دقيقة بعدل المي.
Moving on to our next lecture, breaking down barriers and bridging the gap for dental patients with special needs, special healthcare needs, presented by Dr. Hassa Al-Badr. Dr. Hassa obtained her dental degree from Kuwait University. She has a doctorate in pediatric dentistry from Leeds University and the membership in pediatric dentistry from the Royal College of Surgeons of Edinburgh. Dr. Hassa is a certified autism specialist. She currently works as a specialist pediatric dentist as a full-time faculty member in the Kuwaiti Board of Pediatric Dentistry and the Cleft and Craniofacial Unit at Al Farwaniya Specialized Dental Center. Please welcome Dr. Hassa Al-Badr.
We can't always trust technology. Okay. Excuse me? Yeah, وأخيراً. Okay, let's just check the clicker. Come on. Okay. Yeah, there we are. Okay. أرفعه? Yeah? Okay. وأخيراً. So, good morning. What I just did there is not just sign language. If you notice, I said good morning, I signed good morning, and I also showed you a symbol that suggests good morning. This is Makaton, and I'll tell you about it later in my talk, so keep in mind. So, when you think about any patient with special healthcare needs, a certain image naturally comes to mind. So it could be a patient you've treated, it could be a family member, or someone you've seen in public, which is on a wheelchair. So the AAPD has defined special healthcare needs as any individual with physical, developmental, mental, sensory, behavioral, cognitive, emotional, and any limiting condition that requires medical intervention, any condition that requires specialized care services or any healthcare intervention. Now, these conditions can occur isolated or in combination. They may be congenital, they may be acquired due to disease or trauma such as war. So I really hope the best. والله يفرجها على أهل غزة. Now, these conditions have many limitations and many barriers when seeking dental care, when trying to maintain their oral hygiene. So it limits their daily activities, it limits their daily oral maintenance, and they're usually dependent on others. So the WHO has estimated that there are about 1.3 billion people experiencing significant disability worldwide. So that is about 16% of the world's population. To put it into perspective, it's about every 1 in 6 people. Now, some of these disabilities may be permanent or temporary, and in Kuwait, according to the Public Authority for Disability Affairs, there are 63,380 individuals registered as having a disability. Now, I think that there are a lot of individuals that are not represented in these numbers for various reasons, which won't go into detail into today, but I'm happy to explain to you later on. So, as I said, they face a lot of barriers when seeking healthcare in general. So, they have very poor access to healthcare globally. They may be denied treatment from the healthcare providers due to lack of familiarity or training. They may have impaired communication, so they might not be able to express if they're in pain or if they are uncomfortable. And due to their impaired communication and many different sensory disabilities, they may have a different behavior than what we usually see in a healthy child. Parents may be very anxious to bring them to the dentist because they're worried that the dental treatment might affect them negatively or in an emotional level. Some may be home or hospital bound. They can't leave the house, they can't leave the hospital. It's very hard to bring them to a dental OPD. And as I said, they have a lot of limitations when maintaining their daily oral hygiene practices. So because of that, it's very important that as a team in Kuwait, we work really hard to establish a dental home for every single child, whether they have a special healthcare need or not. And I won't go into detail. I'm sure you know all the importance of an early dental home. And you know, special healthcare needs, they have a risk factor. They're at a high risk factor of developing caries due to various reasons, whether it's the medications they take, whether it's ability to maintain oral hygiene, whether it's the disease or disability itself imposing certain dental anomalies. And there are a lot of nutritional considerations that will affect their oral health negatively, whether it's their decreased ability to consume adequate nutrients or their inability to utilize adequate calories, such as in gastroesophageal reflux. They may be having an increased caloric requirements to grow and develop normally. So they may be supplemented with high caloric formulas, such as Pediasure, and it's filled with sugar. So they're prescribed Pediasure and they're asked to consume it for as long and as frequently as they can. So imagine the amount of sugary attacks they have per day. Now, as dentists, we have to be supportive of these recommendations. We cannot tell them to decrease their consumption of Pediasure or whatever they are trying to eat just to develop normally. So we have to really support them in maintaining an excellent, optimum dental home. So there are many challenges when it comes to brushing their teeth. So they might have a hyperactive bite, such as those with cerebral palsy. They may have a gag reflex. They may not accept the toothpaste or the toothbrush. They may not be able to hold the toothbrush to brush their own teeth. So I'll talk to you about how to tackle these challenges in the coming slides. Now, more specifically, patients with cerebral palsy, patients with arthritis, muscular dystrophy, and autism have limited manual dexterity, and it possesses a great challenge in them being able to brush their teeth. So if the child is willing to brush their own teeth, we should be supportive and try to help them by advising to do some toothbrush modifications so that they are able to hold the toothbrush. So we can either make the toothbrush bigger, we can either make the toothbrush easier to hold, or we can recommend other toothbrushes, such as using a powered toothbrush. So by nature, powered toothbrushes have a larger handle, so they're easier to hold than a manual toothbrush. Now the heads are smaller, so it's easier to reach, hard to reach surfaces, especially if they have limited mouth opening. They may use a three-sided toothbrush, which brushes all the surfaces in one motion. You can customize the handle, so you can just bring some silicone putty and use their hand to customize the handle and just use their normal toothbrush as they wish. And people have been creative in modifying these toothbrushes. They've used foam rollers, they've used elastics, they've used bike handlebars, and for some, they found that bending the toothbrush, so if it's a plastic toothbrush and you run this under hot water, it's malleable, so you can bend it, and it's easy to reach the back surfaces. Now, if the child is not able to brush their teeth on their own for many reasons, it's very important to include the caregiver. So we have to be really considerate consider the social dynamics of the family, who's responsible for taking their daily hygiene in general, so who's changing their clothes, washing them, and so on, feeding them. So that's the person that's most likely to help us establish the dental home. Now, sometimes it's very hard to keep their mouth open for a long time enough to brush their teeth. There are several techniques you can advise them to do. So you can use the toothbrush technique and ask them to use one toothbrush handle on one side of the mouth, and then ask them to brush the other side with the toothbrush, and then you switch. Another method you can use is use tongue blades, so they can get about 5 to 10 tongue blades, wrap them with a gauze, secure it with a plaster, and then that we can make sure that this doesn't hurt their cheeks or soft tissues, and just use it as a mouthwash. Now, positioning them is also sometimes a challenge. So we don't have to expect them to go to the bathroom and just be near the sink, okay? The bathroom is a very loud area. It's a very highly lit area, so if they have sensory issues, it's not the best place. They may have some mobility issues, so they can't stand on their own. So I always tell them, you know what, wherever they're comfortable, just brush their teeth. So be it laying on the adult's lap, they can just sit on their wheelchair if they'd like. Sometimes you need 2 adults to help you, which is normal. And if there's only one adult and they're struggling on their own, you can advise them to use this technique. So you tuck in the arms of the child under the thighs, put the head between the thighs so you secure the head, and then you can just lift the lip and brush the teeth. So you can all demonstrate all these techniques in the clinic. Okay, so you can tell them, you know what, come to the clinic, bring your toothbrush, and we'll try the different techniques and see what works with you. And if they have a gag reflex or a toothpaste aversion, there are a lot of unflavored toothpaste in the market, such as Spry and Oranurse. You can use non-foaming toothpaste, so any toothpaste that do not have sodium lauryl sulfate. So that's the product that gives the foaming properties of all cleaning hygiene products, such as shampoos and so on. Now, once we've established the dental home, how do we transition them to bring them to the dental clinic? So we have here a virtual patient. So we have Ali, he's 4-year-old. Is the mic okay? Yeah. And the parent comes requesting for an appointment. She tells you, well, we've been to many dentists. No one was able to examine him. And I think he needs to be seen. And you ask the mother, well, is he in pain? She says, no, I don't think so. He's been eating well, sleeping well, but I just want to check his teeth. So before bringing Ali to the clinic, you can tell the mother, you know what, I'll give you a practice kit. I'll give you a gloves, mask, and a mirror. And I want you, every time you try to brush his teeth or check his teeth, wear the gloves, wear the mask, and use the mirror every single time. And that helps desensitize him. And you can go over like counting. So you can tell the mother, you know what, put the mirror on the right cheek, count from 1 to 5, then the left cheek, 1 to 5, lips, tongue, and so on. And you get the idea. Until Ali is able to keep his mouth open for at least 20 seconds to facilitate a dental examination. Alternatively, if you're planning to do a professional prophylaxis in the clinic, you can advise her, you know what, introduce him to an electric toothbrush. There are a lot of electric toothbrushes that are just cheap. Just use it. Let him see if he can tolerate the sensation of the vibration or not, and then we'll work from there. Okay? Now, before we bring all these patients and accept them and invite them to our clinic, we have to make sure that our clinic is ready to accommodate their needs. Now, there are 2 main concepts that are used when designing any healthcare facility. And these 2 concepts focus on accessibility and universal design. Now, with accessibility, it mainly improves the physical access. So any person who's using a wheelchair is able to transport themselves from the car until the dental clinic without assistance other than using the wheelchair. However, with the universal design, it focuses on other needs. So we have to design the clinic based on some sensory needs, some visual needs, and so on. Okay? So with accessibility, most of the healthcare facilities have focused on that. So we have a lot of elevators and ramps everywhere, even in malls. Okay? As for the universal design, to be honest, when I first worked in Farwaniya and saw all the painting and the door frames, I thought to myself, who designed this clinic? Why is it so colorful? This isn't a school. I used to be very, I didn't understand, to be honest, okay? But once I started reading, I realized that everything was done for a reason. So if you notice, the handrails here are easily visible, and the location of the handrail is within reach. And you see that there's a contrast between the wall and the handrail, so even if they're slightly visually impaired, they can see it. Okay? The same thing with the door frames. If you've ever been to Farwaniya, you'll notice that every single unit have colored door frames. And it's a gradient, so they know how far is this door. They can see if the door is closed. Okay? The doors are very wide, whether it's the clinic's door, whether it's the entrance door, whether it's the elevator's door. And there are many other things that, unfortunately, they are not available everywhere. So having closed captioning for audio and video messages. So this is like subtitles with explanation. Having large print, which is more or less, sometimes I see that, sometimes not. And finally, having dimmed lights. So those with visual sensitivity can tolerate the lighting. Okay? Anyway, this isn't supposed to be here. So teledentistry is something that we can also incorporate as part of the universal design because it improves accessibility for those who are not able to reach. And what I mean by teledentistry is giving the patients the ability to communicate either directly, so they can call the doctor or the healthcare provider, or by leaving some direct messages or videos and so on. Unfortunately, currently it's not available, but I think that we have the resources to implement that in the future, inshallah. So let's go back to Ali again. Okay, let's see, why didn't he manage to have a dental exam done? And he's seen several dentists. So Ali has sensory processing difficulties. If you go back to, let's say, your primary school years, they taught you about the 5 senses and so on. Now, with sensory processing difficulties, each sense is different than normal, okay? So it's either that if I was Ali, this light would be too bright. I would just stand there and close my eyes. The speakers would be too loud for me. I wouldn't be able to tolerate them. He might not be able to tolerate any taste of toothpaste, frothy, certain foods. He might have a sugary diet. He might be put off by certain smells. So dental clinics usually have a very strong smell due to the materials we use. And he may have some sensory processing difficulties with the vestibular system. So if you put the dental chair down, he might be startled, okay? You can notice that in some babies if you're trying to wash their head. So my daughter has this. The minute I just put her hair back, she just startled and starts to cry, okay? It's sometimes normal in typically developing children. So as I said, these sensory processing difficulties may be observed in typically developing children, okay? So I'm not here to diagnose Ali and say he's autistic or not. This isn't my expertise. But we have to be aware that it doesn't only affect those on the spectrum. It affects those with ADHD, developmental delay, Fragile X, and as I said, typically developing children. Now, what can we do to accommodate those sensory processing difficulties? You can prepare them before they come to the visit. So I explained the practice kit that they can use at home. You can make changes to your dental environment, and there are certain things you can do in the dental visit to help them accommodate. So what we have in Farwaniya, and I'm so proud of the team that I work with because they have done a lot to tailor the dental care for these specific individuals. So we have a questionnaire asking, we can give it to the parents before they come to the clinic, and we want to know, well, is your child verbal or not? How do they communicate? Do they have any sensory issues? And that will help us and guide us to specify our treatment based on their needs. Okay? So we want to know, is there something that calms them? Is there something that agitates them? Okay? And we also have part of the form an area where they can share anything else that's not covered with the questionnaire. So as I mentioned, we want to know if they're verbal or not. If not, some of them use some special communications, alternative communications, such as the picture exchange communication system, where they use specific diagrams and they make sentences from these. Okay, so you see here, I want big green blocks. And you can mix and match, make new symbols and so on. Now they're developed into electronic means, so they may have an iPad where they use to communicate. Okay, I haven't seen it, to be honest, but I've heard that there are a few patients in Kuwait that use these. Okay. Remember Makaton? So this is the lady behind Makaton. She's a speech therapist in the UK. She went and worked as a speech therapist in an institution. And what triggered her to develop Makaton was that one of the residents bit her. And she thought to herself, why did he bite me? What did I do? And she noticed that many of them actually have communication difficulties. So she thought to herself, well, I know sign language. Why don't I try to teach him sign language? So she started teaching some of the patients sign language while talking. So most of them can hear her. So she uses sign language in combination with some symbols. Okay? And it has been proven that using signs with symbols and speech together encourages communication and language development. So if you've come across baby sign language, these babies who know sign language are less likely to cry because their parents understand what they want. They won't be crying all the time. They will sign, for example, if they want milk, right? So this reduces frustration, and this will help their cooperation. So if we are able to communicate with our patients, this will really help us a lot, and help the patient, of course. So luckily in Kuwait, there's a Makaton Center. Now, this Makaton Center doesn't only accept patients with autism. It accepts any patients with communication difficulties. I'll just show you this video here. So the sound is not on. What the teacher is doing, if you can see, there's a house symbol and a house toy, and she's signing for him, Menzil. Okay? So using speech, signing, and symbols together. Okay? And this center is willing to train any person who is interested, whether it's a healthcare provider, police person, ambulance, teachers, even those who work in retail and see those patients. So feel free to contact them if you're interested. I am planning to take the course myself. And there are many symbols that you can find online that you can use, but make sure that the Arabic Makaton is using the same symbols. Okay, so you see here, you can make your own when you work with the Makaton Center. Imagine if you take this paper, print it double-sided, so you'll have the symbol of a dentist printed behind the signing of the dentist. So it's a good prompt card when you're trying to learn and communicate with your patients. Now, other supports you can use in the clinic is using a visual schedule or social stories. So a visual schedule, a picture says more than 1,000 words. So this picture probably says 1,000,000 words. And it just takes the patient step by step on what are the steps that will happen during their dental visit. Okay? And you can see here, you can customize it depending on what are you planning to do. I don't want to see myself on the screen. Okay? If you go to this link, you'll also find some other resources. You can just translate them. And what you do, you give that to the parents, and ask them to read it over and over and over and over before their visit. And preparation really helps cooperation. So as I mentioned, a social story is something similar. You can take pictures of your facilities and write a story. And the story is usually written in a very straightforward language, and it's written in the perspective of the child. So if you see here, أنا أركب المصعد وأضغط على رقم واحد. So it's as if the child is speaking to me. Okay? They're not spoken to. And you, same thing, you ask the parents to go over the story again and again and again before their visits. Okay? So you see it goes over all the steps of the examination visits. Okay, so what can we do to the dental environment? What adaptations can we do? So depending on the sensory processing difficulty, you can mix and match. So whether it's a visual sensory processing difficulty, you can adjust the decor, so you can paint the walls if you can. You can dim the lights. You can even turn off the lights if you want and ask the patient to just wear blackened sunglasses, okay? If it's a hearing sensory processing difficulty, make sure that the area is quiet. You can schedule them at the beginning of the day before your patient comes, or towards the end of the day when most of the patients are done with their treatment. Or you can use noise cancelling headphones, soundproof rooms, and so on. You don't really have to make it expensive and complicated. Yeah. And they're very sensitive to smell, so instead of using prophylaxis, you can use pumice, which is tasteless, but maybe the texture might put them off. I don't know. You have to try. You have to give it a go. And then in the waiting area, you can have rocking chairs, different seating options. They may be irritated sitting on just a plastic chair. They might want to sit on a beanbag. So you can mix and match, or you can have a separate waiting room for them. Okay, so this is the sensory adapted dental environment clinic we have at the KBPB in Farwaniya. And I'll just explain to you how you can do your own in your clinic. Okay, I'll skip that. This is the clinic. You don't necessarily have to paint your wall, okay? You have a blind. Blinds are pretty cheap. You can have even a blockout sticker thing you can put on the window. Before your patient comes in, recline the chair, okay? Turn off the lights. You may use the headlights only and just put it on the teeth, or use a specific headlamp. And finally, you can have some moving lights in the ceiling to distract them, okay? So this is mainly adapted from this New Zealand environment, if you've heard of it. You can use a weighted blanket. Somehow, their tactile receptors are a bit different. They're light touch receptors. So the receptors that tell you, well, there's a hair on your skin, or there's a fly, or there's a plastic paper. For them, this is very annoying. And it really makes them frustrated throughout the day. But somehow, if their deep pressure touch is activated, so hugging them, massaging them, using a weighted blanket, or even using a butterfly wrap, calms them immediately because it regulates the light touch receptors. Finally, with the dental visits, desensitization, and it starts at home, okay? And you can continue desensitizing them in the clinic. As I said, with sensory considerations, consider the taste, consider the sound, consider the light, okay? And finally, routine and sequence. So whatever you do in the first visit, do it in all consequential visits. And make sure you write that in your notes. Who's the person who greeted the patient from the waiting area? Was it you or your nurse? Make sure it's the same person every time. What did you do first? Did they lay back on the chair, or did they sit on the parent's lap? And so on. And you get the idea. So we have another child. So Sarah has hearing impairments. What can I do? How can I really help Sarah? Yes, most of them come with their parents. Their parents will tell me what's going on, right? But we have to include these children, even though they have these impairments. even though they have communication difficulties. We have to really put in efforts. So face the patient when you're talking, even if they can't listen to you. They may be able to lip read. They may be able to read your face and body language. You can use augmentative and alternative communication depending on what they're using. And I wish in the near future we can have a sign language interpreter that we can just call, video call, and tell them, you know what, I need your help. Talk to the patients and tell me what's going on. I don't want to speak to their parents only. I want them to feel included. I want them to feel important. And finally, if you've heard about this application, تطبيق الترجمان. So what it does, you can write what you want to say to the parent, and it will sign it for you. And it's mainly in اللغة العربية الفصحى. If you write an uncommon word, it will just spell out the letters for you. And a lot of programs are now being developed using AI, and they try to interpret whatever the person signing is telling you, but I'm not sure if there's one in Arabic. I'm sure there's one in English. Okay? So it takes a village to raise a child, and it takes more than a village to help a child with special healthcare needs. So you can involve an occupational therapist. They can do a lot. They can help with motor skills development, so help you with the toothbrushing, help you with the sensory processing and how they can adapt to the dental environment, help with posture and nutritional management. So make sure you know and meet the team of occupational therapists in your governorate and nearby hospital, and see what can you do to work around and help those patients. Finally, there are a lot of facilities that provide care for this population in Kuwait, and I'm pretty proud of what we have achieved so far. So most of you either work in one of these centers as pediatric dentists, and inshallah كله أجر وميزان حسناتكم, because all of these centers provide care for children with special healthcare needs who are 0 to 12. Okay, all sorts of treatment is provided under GA, under local, and so on. We also have the dental clinic in Al Sabah, which provides care for mainly medically compromised patients who are seen in Al Sabah and NBK's Children's Hospital. However, unfortunately for this, in general, they are not seen early. Okay, so we'll have to work around seeing all these patients from day one. And you're aware of the cleft and craniofacial unit in Farwaniya, which is an amazing unit. There are dental specialists, medical specialists. So in a single visit, the patient may be seen by a plastic surgeon, oral maxillofacial surgeon, speech language pathologist, pediatric dentist, orthodontist, ENT. Imagine that. So the collaborative care that is being provided is amazing. And they have a website that you can send to your patients. They can read more and know about the condition. And if you want to refer, you can also use the tab for the healthcare providers. So it's, in case you can't see, it's thespecialsmiles.com. And finally, once they're above 12, they are transferred to our colleagues in the special care dental units. So these units are available in most governorates, and they accept most of the special healthcare needs patients who are aged 12 and above, including oncology patients. I wish for a better future in Kuwait. So I told you what I wish in the future, and most of them are there. And hopefully, as a team, we really improve the services. We provide teledentistry, better training for all the supporting staff. And my main goal is to start a dental home at birth, not even by one. At birth is when we should start. Thank you for listening.
Thank you, Doctor, for the very interesting lecture. Now we will welcome any questions.
Anyone have any questions?
I just want to know, is anyone interested in learning Makaton? Raise of hands. That's a huge number. I think we can just ask them to train us and see if our patients are willing to.
Thank you, دكتورة حصة. دكتورة حصة, can you come here, please?
Check one, check.
Our next lecture is presented by the Head of Special Needs Dental Unit in the Ministry of Health in Kuwait, Dr. Munira Zenki. The lecture title is Special Needs Patients. Dr. Munira had obtained her BDS from Liverpool in 1999, membership of the Faculty of Dentistry of the Royal College of Surgeons Ireland 2007, Advanced General Dentistry from the RCSI Ireland 2010, MSc in Special Care Dentistry from the UCL University in UK 2016, and she's currently working in Al Amiri Specialized Dental Center. Please welcome Dr. Munira Zenki.
الصوت واضح؟ أو جزء من I don't feel confident to start up to you صراحة. والفلاش مش طالع هنا. تنقل لي هذا. لو سمحت. مو طالع. عندكم يا. السلام عليكم ورحمة الله وبركاته. معاكم منيرة الزنكي. في وجوه مألوفة وفي وجوه ما أعرفها. حياكم الله. I usually get nervous in the first 5 minutes. بعدين راح استن. I promise you it will be interesting. I'm used to 1 hour and a half to 2 hour lectures to present my department. Unfortunately, I'm squeezed into 45 minutes, so I'm gonna pinpoint into what we are doing, and I'm gonna pause on cancer therapy and hemophiliac patient, just to focus on them and give them what you need to do when you have the patient in the clinic. The title of my lecture was Introduction of the Special Needs Unit in the Services in the Ministry of Health. Unfortunately, the conference changed my topic into special needs patients. So I thought, I think they don't know what we are doing, so let's take it as they think. They think this is what we do, that we are treating special needs patients only. The broad term of our specialty is special care dentistry. So any patient who needs special care would be treated in our department. So why do we exist? As you know, that medicine has developed, and there are new medications now that guarantee patients to live longer. In years, the patients were dying from diabetes. And if that was the case, I wouldn't be standing here. I'm diabetic myself. I have a pump. So I would be dying 100 years ago because the medicine have developed. I am here now to present to you what's happening. And there is lots of patients with special needs, like the mentally disabled, the very uncooperative patients who were been not treated in the right way before 2013, before the department was established. Before 2013, if you have any patient with medically compromised conditions or with a special need patient, which send them to surgery and they have their teeth extracted under GA. Basically, that was the treatment available. No patient had the right to have a filling or have a fluoride varnish applied because of the difficulty of their case. So, alhamdulillah, since 2013, and this is us after 10 years, I'm here to present my unit as we have extended, alhamdulillah, into so many centers. We are presented, located in Amiri Dental Center when we started. We have Al-Farwaniya Dental Center, we have Al-Adan Dental Center, and Al-Jahra Center. And inshallah soon, in the beginning of next year, we're going to start Jabir Center. So we have the whole Kuwait, inshallah, covered. And those who don't have the center will be referred to the main centers, which is to Amiri. What do we treat? What are the categories that we treat in our department? Assalamu alaikum. Basically, we treat the mentally disabled patients, the uncooperative patients. We deal with patients with psychiatric problems, referred from the psychiatric hospital. We see patients who have medically compromised, but the ASA 3 and 4, which I'm going to explain more later. We deal with Alzheimer patients and the bedridden patients because they are the most difficult of the elderly sector. We see patients who are newly diagnosed with cancer and they have to go for chemotherapy and radiotherapy. So we have to make sure that the patient is dentally fit to proceed with the chemo and radiotherapy. And last but not least, the congenital bleeding disorder. On the top of that, any patient who is very difficult, a condition you never heard of, you're too scared to see the patient will be referred to our center. The whole idea of the unit, it's built on identifying the risk. If I have a patient who's diabetic, so the first thing I would think, what's the risk that comes with the patient? Usually it would be a hypoglycemic attack. If I have a patient who's have a bleeding disorder, the main risk we'll be thinking about is excessive bleeding. So the idea of the whole department is to identify a risk first, then try to avoid it. And if you cannot avoid it, make sure you know how to manage that risk. Make sure you have the tools that you need to manage this patient. How do we do it? We treat the patient both in the clinic and in the hospital. In the clinic, we do physical restraint with the permission of the parents, just to limit the patient movement and hand movement, basically. We see the patient. If we need an extra tool, we can go for inhalation sedation or oral sedation. We don't prescribe the oral sedation ourselves. Usually we refer the patient to the psychiatric hospital, and in there, those who have files already can be prescribed oral sedatives to enable the dental treatment in dental chair. Usually 1 tablet or 3 tablets pre-appointment according to the medication prescribed and the strength of it. Then if it's too difficult with physical restraint, inhalation, oral sedation, we have to go into the last option we have, which is the general anesthesia. We prefer not to jump into general anesthesia straight away because of the long waiting list and the short operation slots that we have. So we try our best to manage the patient in the clinic, which is when it's safe to the patient and it's safe for the dentist itself. So how do we do it? We try to make it as comfortable as possible for the patient. So it's the patient in control, it's not us. We follow their commands, we respect that they don't want to sit on the chair, and we can always do it in a way that's comfortable for them. This is one of my colleagues who's examining the patient standing up. This is the patient who's to be examined as well. He was supposed to go into general anesthesia, but after we examined the patient only had erupting 7. So thank God we did not go and listed the patient under general anesthesia because there wasn't no need to waste time and the slot that another patient who's really needs the slot to have the operation done. Wheelchair-bound patients can be treated as well, but in their own chair. Basically, we have this nice tool, you can always flip the head of the dental chair. I know that some people don't know that, but you can do it simply. Let the patient face his back to the chair and flip the head. So you can rest the patient, he has support of the neck, and you can always operate on the patient. I pressed something wrong. Okay. When we say inhalation sedation, we skipped inhalation sedation. Sorry. So this is the wheelchair, then inhalation sedation, which is very helpful in calming the patient down. It's not a total control, but the patient would be less resistant and more accepting of the treatment itself. We're still giving local anesthesia when we work to control the pain. And it doesn't work most of the time with our mentally disabled patient because they don't understand they have to inhale from the nose and keep the mouth closed or blow, So you have to give it to a patient who can listen to instruction and can apply it itself. General anesthesia is not easy as you think. This is a patient referred to as general anesthesia, and there are 11 technicians and anesthetists just trying to fix a cannula for the patient. So when the patient is giving the option, go to Amiri, they will do your teeth under general anesthesia, it's not easy. It's not easy at all. And we only refer the most difficult patient to general anesthesia. We don't do it for fun or just to make the patient feel better, because they really need it. And believe me, the anesthetists in Amiri don't like me much, because once they see our list, they know they're going to have a challenge for them, and we always make it interesting. This is us operating under general anesthesia. Bedridden patients as well are seen in our department. Usually the patient come by ambulance. They go into the clinic and we treat them on the bed itself. We have the facility of raising the bed or keeping it down. We can always change the bed position, the head of the bed position, and it's not the most comfortable, but it's doable. And most of the patients who's bedridden, especially the elderly, the type of treatment they need is limited to extraction of remaining roots or fractures or removal of a loose bridge that they have. It's not that complicated, and it is, alhamdulillah, doable. Let's move to our patient. We talked about the bedridden patient, then we have the Alzheimer category. I wished I can give you a case of each category that I see, but unfortunately, the time is very limited, and I'll try to be selective on the cases. Alzheimer's, lots of famous people have Alzheimer's, not only our patients. Bruce Willis, recently diagnosed with Alzheimer's, and Robin Williams as well. The Alzheimer patient, we can give another lecture about it because it's the most difficult disease anybody can have. If I have to choose between cancer and Alzheimer's, I will choose cancer because cancer is treatable, but Alzheimer's is not. Mentally disabled patient, which is, we are well known as special need dentist, treating the mentally disabled patient. The most challenging category I have is autism. They are very challenging, and the cooperation is very limited unless they are the smart part who have, there's certain type of autism that can be very smart, like Steve Jobs, he have autism, Einstein have autism, and least but not least, Bill Gates. They have what's called Asperger's syndrome. This is a type of autism. So don't think that all autistic patients do not understand what you are saying. Give yourself the chance to speak to the patient, respect the patient, and you maybe will be surprised what type of autism he has. Most of the patient, the autistic patient, the uncooperative ones, are treated under general anesthesia, but we still follow them up in the chair. So we do the operation, but we follow the patient in the chair. ADHD, the attention, distraction, hyperactivity disorder. Guess what? Leonardo da Vinci has it. And they claim that the Mona Lisa painting is not completed because he had ADHD. That was very surprising to know. He couldn't complete it. So we have a $1 million painting which is not completed because the patient have a mental disability disorder. Back to the wrong buttons. Oh, look at that. What about this view? Okay. أدري قاعد ألعب فيه ما أقدر ريموت بالبيت حتى والله. Can I have a tissue please? Don't give a remote control to someone who works with special need patients. Okay. Mental illnesses. Lots of people have severe depression that reaches suicidal. Mel Gibson, he's bipolar. So many actresses are bipolar. They said that their job influence and speed up the condition that they have. Leaving the mentally disabled, the mental illnesses, moving into the medically compromised patient, which is a big sector that we see in our department. Soon we're going to have it shared with our friends as well. So what do we see? Who are patients who are referred to our department who are medically compromised? Sorry. I had the slide of the ASA 3 and 4, but basically, patients who have a medical condition that's limiting their activity is the ASA 3. ASA 1 is the healthy patient. ASA 2 is the patient who have an illness but it's controlled. Those usually seen in the polyclinic because they don't have any special things to be done to them. But the ASA 3 and 4 are the categories that has to be referred to our department because they are at risk because of their conditions that being uncontrolled. Selena Gomez, she has SLE, systemic lupus erythematosus. And guess what? 2017, she had a kidney transplant. So even famous people, actresses, singers, they look healthy, but they are medically compromised. And you'll never know unless you go through their medical history and you have to question them. So the idea of today, special needs patients are not only with wheelchair and those who don't communicate. Even those patients are special needs. Melton Williams, who's a very famous talk show presenter, he's diagnosed with MS. You know that MS has attacked people between the age of 20 and 40, and it's increasingly, the numbers are increasing very, very fast in Kuwait. Congenital bleeding disorders, that could be just a presentation itself, but these patients, basically, you have to plan them really well. You know, it's not you get the patient who wants to extract his teeth, you put him in the chair and you just give a local anesthesia and you pull the tooth. No, no, no. For these patients, you have to plan it really well with the hematologist. Make sure you have the right tools, make sure you have the right blood counts, factor counts, whatever they need. So I'm going to touch only on the thalassaemic patients. Oh my God, this is the wrong presentation. Anyway, I can continue. Let's talk about sickle cell. I had two cases for you, but I'm going to present the sickle cell. Sickle cell anemia is inherited autosomal recessive condition, mainly affect the dark-skinned people, very common in Africa. Usually, you have to have good understanding of the disease because the patient comes and he goes, I have sickle cell anemia, and you don't know what he's talking about, you cannot treat the patient. So always give yourself time to think about the disease, read about the disease, or consult someone who knows about it. The main thing about the sickle cell anemia disease, there are special factors that initiate or give them the sickling crisis. Sickling crisis mean the normal blood cells, they change the shape from the round shape into like a sickle, like the moon, مثل الهلال. They look like a C-shaped. They get stuck together and they can block any artery they have. If they block the artery of the eye, the patient will have stroke in the eye, he will be blind, he will have stroke in the pancreas, he will have diabetes, or he have stroke otherwise. Okay. Implication to us, when you have a sickle cell patient, you have to have short early morning appointments, early in the week appointments. But when it comes to consent, the patient can consent because they have the capacity, okay? You have to make sure the patient have the right amount of blood. Usually patients who are going for major surgeries or for surgical extraction, they have to have blood exchange before they come to the clinic. I'm not liking this tool. Okay. So anesthesia of choice, you can go with local anesthesia with epinephrine. There is no problem with it. Inhalation sedation can help reduce the stress. There are so many factors that can start the sickling condition. One of them is hypoxia, 2 is stress, and 3 is the attitude. So basically you have to avoid all these stress factors that can initiate the problems. And one of them is to give effective local anesthesia to make sure the patient doesn't have the stress. Sedation can help the patient to give him extra oxygen and reduce the stress as well. Avoid conscious sedation because of the hypoxia risk, depends on the B12 concentration. General anesthesia, you have to have the right concentration of the right blood cells, or you have to transfuse blood for the patient 10 to 15 days pre-op. This is just an example. I'm going to skip. Okay. I'm just going to skip this one. I'm sorry. This is my slide, not that one before. Okay. I want to talk about hemophilia, okay, because this is my favorite sassy topic. Hemophilia comes in 2 types, type A and type B. The most common in Kuwait is type A, which is the missing of factor 8, coagulating factor in the blood. The risk is the patient has, when you can diagnose this from just, if you see a patient who comes in the clinic and you just have a random probing of the gum and you have excessive bleeding with good oral hygiene, you have to think about hemophilia. Usually hemophilia diagnosed when the patient around age 7 to 8, when they above 3 years old, when they start to move, when they have trauma. This is the time the parents would know there is a problem with the bleeding itself. Usually you have bleeding from the gingiva, or you have excessive bleeding after extraction. There is always a risk of upper airway obstruction secondary to severe bleeding from the floor of the mouth. How do you manage a patient? You have to consult the hematologist. You have to assess the severity of the hemophilia. You have to see if the patient needs to have a factor transfusion or not. You have to assess the treatment in the clinic, if it can be done in the clinic or in the hospital, depending on the number of teeth to be extracted. And you have to be careful about choosing your local anesthesia. Always refer the patient and get consultation from the hematologist. Explain what are you doing, the number of teeth to be extracted, and the factor concentration you want from the hematologist to provide for you. Because when it comes to hemophilia and you have to give an ID block, you have to have 50 to 70% concentration of the factor. The same thing goes if you have to going to operate on the patient and under general anesthesia, you have to have high concentration of the factor. There is some procedures you can do in the clinic without transferring the factor to the patient. For example, if you're doing a class 1 cavity on the patient, not expected bleeding to be done, non-intrusive procedure, you don't have to have the factor transferred. Some procedures require factor level to be like 30%, for example, ID block, but you go for a major surgery, you have to have a higher concentration of the factor. How do we consider if the case is severe or not? It depends on the factor activity, if it's above 5% or less, and according to that, you know when to transfer the factor or not. When it comes to local anesthesia and the risk of hematoma, you have to avoid the floor of the mouth and try to avoid ID blocks as well. Infiltration using slow injection technique is very important. And if you have a finger gauge single-use needle, you don't even have to need the factor. Lingual and floor of mouth, we said you avoid because you don't want to have to create hematoma, and that may block the patient's airway. Factor replacement, usually they reflect the fact, they usually give the concentrate of the factor itself, or they give the fresh frozen plasma having the factor in it. Timing is very, very important because you have a window to work with. Timing of the administration of the factor is very important. The factor level declines very, very fast. So you have to have sure that the patient's transfusion place is next to your clinic. I can't get the patient to have the factor transferred in Mubarak Hospital with the traffic to reach me in Amiri after 40 minutes. That's too late. So usually you have to allow 45 minutes for the factor to be transferred to the patient. Check the patient level after 30 to 60 minutes. After that, if it's a sufficient level, you can work, and you have only 30 to 60 minutes to do your operation or your actual procedure. If the factor level is still low, you have to transfer again. So it's very important to check the factor level post the first transfusion. You can give prophylaxis or on demand when bleeding occurs. Usually a patient comes with the factor in their hands. They have the transfusion and they have it in their bags. They bring it with them. Sometimes we keep it in the bridge for them for after procedure, and sometimes they just know how to monitor it itself. Recombinant factors is reduced, it's manufactured, it's not from humans, so the chance that you have blood-borne infection is less, but you have to know that the factor continuing transferring for the patient factor all the time, it's very expensive, number one. If it's using the manufactured one, it's very expensive. If you use the human one, there is high chance the patient will develop the autoimmune. So it's better that when you give the factor, you make the use of it, and you do as much as possible of procedures needing the factor itself. Post-op, you can always give the patient tranexamic acid. Some patients take it as prophylaxis before the procedure and continue to take it for 3 to 4 days post-op. So many questions I got when I started is how do you read your blood investigation? I just was going to put that just for a few minutes for your knowledge, because don't get confused with all the numbers that you see. Us as dentists, we have to focus on certain numbers, and we have to know what's affecting our procedure. So basically from all of that, if I'm going to extract a tooth for a healthy patient, okay, or a patient who's anemic, for example, what am I looking for? First of all, you have to check the hemoglobin level. Okay? Out of the whole thing, you have to know your hemoglobin level. So for the male and for the female, there's a difference. For us to proceed, you have to have your hemoglobin level above 100 or above 10. So this is your benchmark. Anything below that, do not operate. You have to have that corrected. Or repeat the blood investigation to make sure you have the normal level. Why is that? Because you want to avoid hypoxia. Hypoxia means the hemoglobin is the oxygen transferring molecule in the blood. So if you don't have enough hemoglobin, you don't have enough blood coming to your brain. So if you don't have that, you're going to have hypoxia. And the reducing oxygen to the brain can cause brain damage. So you have to make sure you have the right now. When it is decreased, when is it increased? Mainly it's decreased when you have deficiency in iron, B12, or folate. Some patients who have acute or chronic blood loss, for example, are post-road traffic accidents, or both post-birth, when patients have delivered either cesarean or normal, the blood will drop. So this is like an acute blood loss. Some patients have red blood hemolysis, for example, in sickle cell anemia. They have reduced blood counts as well. Same in leukemia and thalassemia. So when you see the blood investigation results, just focus on hemoglobin to start with. Okay? When is it increased? When you have dehydration, congenital heart diseases, pulmonary disease, and renal problems. Why is that? Because we have the erythropoietin, which is a hormone that increases the production of the red blood cells. If you don't have it in kidney problems, you're going to have the same problem. Second of all, you have to check your blood counts. You know, that's the function of the platelets is the primary molecules that block the first soldiers in your hemostasis procedure. So if you don't have the right platelets, you're going to have an open wound, it won't close. So you have to primary closure to allow the coagulation factors to perform your clot in the bottom. So what's the average number that we have? Usually it's 150,000 to 450,000. The numbers varies. If the patient has any problems, our benchmark is less than 50. So the patients have platelets less than 50. You have to think about transfusion. 150 is low, but you don't start transfusion unless the patient is less than 50,000. When is it increased? When is it increased? If it's decreased, it's thrombocytopenia. That means low number of platelets, mainly in immunothrombocytopenia purpura, leukemic patient who's on chemotherapy that we're going to talk about later, patient with kidney disease, and patient who have taken medication to make their blood thinners or antiplatelet medication, for example, Profen and aspirin or Plavix. When is it increased? Mainly in myeloproliferative disorders, cancer, inflammatory bowel disease, and autoimmune disorders, connective tissue, for example, SLE. They have high number of platelets, and there is high chance for them to have clots and stroke. So we finished with hemoglobin. We talked about platelets. Third of all is the neutrophils. Neutrophils give you an idea about the patient immunity. It's all about the concentration. We talk about it above 2 or less 2 is the number. Mainly if it's less than 2%, the patient is immunosuppressed, and may we think about giving the patient antibiotic to prevent any superinfection of his wound. It's decreased in immunosuppressed patients, SLE patients, MS patients, all of them are immunosuppressed. Those with bone marrow failures and in chemotherapy as well. It's increased in leukemic patients. Anybody have infection, the number of neutrophils will shoot. That's an indication that you have an infection. White blood cells give you an idea about the whole white blood cells, if it's lymphocyte, monocyte, neutrophils, and eosinophils. But the neutrophils itself is the one that give you the immunity itself, but the white blood cells count in total give you the whole thing. Usually it's decreased in immunosuppressed patient with bone marrow failures and in chemotherapy, increased in infection and in patient taking corticosteroids and leukemic patients. Last but not least, the INR is very appropriate for us, especially if patients taken anticoagulant products as in warfarin. So the normal INR is 1 to 1.1. That's the normal for any person who's not taking any medication or doesn't have any bleeding disorders. But if it's increased or decreased, depends on
15 minutes left, Doctora.
Okay. So prophylaxis, patient, you have to ask about the patient therapeutic range. If someone is taking warfarin, you have to ask him, what is your therapeutic range? If he goes, if you see the number is 3, you said, no, I cannot extract for you, it's too high. No, it's not too high because his doctor wants his blood to be 3.5 or 3. Because you want to make sure the blood is very thin and very flowy to prevent having any clots for him. So this is the reason. So always ask about the patient therapeutic range, and that will give you an indication if you have teeth who have acute PA lesions, but the chronic one, just don't touch them. If they're asymptomatic, not causing any reason for the patient, just keep them or delay the treatment for them. So during chemotherapy, what you need to know. Time of chemotherapy cycle is very crucial because if you're going to extract, you have to make sure you have 10 days of healing time between each cycle and another. And with that, we had the power to stop cycles being given on time. And I'm saying that because we have to indulge ourselves on the medical field because they think at the end, just go and fix your teeth before the chemotherapy. No, no, no. You have to respect that our procedures take time. Our procedure needs time to heal, and then you can proceed with your chemotherapy. You have to have a recent full blood count, a recent one, to check your readings. You have to know what are the intervals between each cycle and another. If it's like a week, 2 weeks, a month or 2. It makes a difference. You have to assess the need for transfusion of platelet or immunoglobulin placement because if the patient's platelets are very low and you have to extract, you have to be above 50. You can go below that. You have to assess the need for antibiotic cover if the neutrophils are low, below 2. That's why we had the blood investigation done before so you understand my readings. When I say low and when you have to replace it. Platelets counts, our golden line is 50. Anything above 50, you have to go for a transfusion, and it has to be 1 hour pre-op, and you have to repeat it within 24 hours. Usually when we have the patient have the transfusion, we see the patient, we do the extraction, he goes back to the ward, he take another 3 to 6 pints, get the blood result checked, and within 24 hours, we're going to give him another one as well. So you have to make sure that your supplies is already available and booked by the patient name in the hospital. Hemoglobin level have to be above 100%. We only think about transfusion if it's above 70, lower than 70. Lower than 70, they start transfusion red blood cells, but before that, they don't. Neutrophils, we said, above 200. The side effects of chemotherapy, this is a very important slide. It took me a while to present it for you. So we had to know when does the side effect start and when does it go away. This is very important. Mucositis start within the 7th day. Sometime within 24 hours, but after 7 days, they're going to have the mucositis. It's a very painful, aching feeling, and it just alayhum. Okay? It subsides 2 to 3 weeks post CT. So when you stop your last cycle, within 2 to 3 weeks, it's gone. It's vanished. It's not there anymore. Okay? Blood changes. Okay? From they start the chemotherapy, the bone marrow is affected straight away. But it's 4 weeks post CT. You have all the blood results back to normal. So after a month, the effect of the chemotherapy on the blood changes just vanish. Salivary flow starts within 12 to 24 hours. You have changes. It subsides after 2 months. Sensitivity of the teeth, it goes for weeks, but it stops after you stop the chemotherapy. The morange, the lecture next door, they talks about it. The effect of morange depends on the medication that you're using. Usually the rituximab's effect subsides after 9 months. So you think about, you give yourself 9 months, but you don't extract. The more you defer it and delay it, the better. Moving to radiotherapy, again, you extract any teeth to be extracted, but you need 2 weeks, post. Ideally, it's 3 weeks. But we never have the time. They never give us the time because they have to start with their cycle or to continue their cycles. So minimum of 10 to 14 days for healing, but the ideal is to have 3 weeks post-chemotherapy that you have the actual total healing of the bone. That's allowed, that prevents the osteonecrosis. Stability of the teeth, Periodontitis, again, extraction of teeth with poor prognosis or perio pockets more than 6 millimeter. Remove causes of trauma is very important. If the patient have fixed appliance, you remove it. If they have ill-fitting denture, they have to do without it or you line it. What you need to know with radiotherapy, it's very important, it's very crucial to know your total accumulative dose that I have with the patients, because it depends. Anything above 60, that limits you with extraction or touching the bone. Okay? You have to know your radiating zone. I'm assuming the patient had an orofacial carcinoma. Okay? But if the patient have a hip carcinoma, okay, or away from the mouth, that doesn't affect your work. He had radiotherapy limited to the limb, but it's not in the mouth, but it doesn't affect. Now, even with oral cancers, they give patient shields, so they prevent the beams to cross the midline. So if they have it on the right, don't extract on the right, but you are allowed to extract on the other side. So still, it's very, it's better than before, alhamdulillah. So you have to assess the need of antibiotics. We said total degrees, recent blood counts. It's not very crucial in this stage, but you have to see the assess of that. No, that's chemotherapy, not radiotherapy. I'm sorry. So avoid extraction. Avoid extraction. So what would you do? Go for root canal treatment. Go for amputation, section of the crown, decrown the tooth, do root canal for the roots, and just seal the tooth, but do not extract. That's during radiotherapy. Okay? Prevention is very important. Diet advice, oral hygiene is crucial for the patient. Post radiotherapy, in the first 6 months, avoid extraction, because the highest risk of osteonecrosis is the first 6 months post radiotherapy. The risk doesn't vanish, but it reduces within 2 to 3 years. Okay? It's not impossible to extract for a tooth post that, but you have to know that there is a time limit for you. Okay? Non-surgical periodontal treatment can be performed within 6 to 12 weeks. Surgical procedures to be deferred after 6 months. Okay? Any partial removable prosthesis to be applied after 6 to 12 months. Oral hygiene is very important. And again, delay orthodontic treatments. Side effects of radiotherapy, as we know, when do they start? When they resorb? Xerostomia is resorbable. This is very heart-aching, because to have a dry mouth, I have it right now, it's very difficult. So other things can be better. The osteonecrosis, the risk of osteonecrosis is reduced after 2 years, but it's still there. Can you give the patient implants? Yes, you can. But you have to make sure that the number of grays is below 34. So it's not impossible for the patient. I finished in time. Wow, never done it before. Just remember our department. Keep us in mind. Trust me, one day you're gonna need us, okay? We are here to give consultations. We are welcome to treat the patients. With the growing clinics in our department, alhamdulillah, we are reachable. We haven't seen a patient complained in the past 10 years, alhamdulillah. Our staff is growing in numbers. New centers are opening. Competing to doctor, I see a good future. I see a good future when it comes to special need in Kuwait. From the dental field, we have people who are willing to help. We have dentists who are willing to fight. We have patients who's taken challenging cases. They're not afraid. They have the knowledge, they have the tools, and they have the good heart to do it. And I'm going to say it in Arabic. Alhamdulillah, we've been blessed. We started, it was just heroic. We didn't have the knowledge. I did it for 2 years because I wanted to help. And alhamdulillah, God was there. After I went to my MSc and I got my special care dentistry MSc, I noticed I've been doing lots of things in the wrong way. But I got away with it because we had good intention. Now that we have the knowledge and we have the good intention, it's growing. It's amazing. We were begging dentists to come and work with us. Now people are calling all the time. Can we join? Can you join? And we say, no. We don't have no vacancy. We're fully booked, So alhamdulillah, it's growing. The next step is to try to give the knowledge. We're passing the knowledge to the dentists in polyclinics because there are lots of cases that you can do it yourself. You don't have to challenge it and send it to Amelia or to Farwaniya or anywhere because it's not that bad. Especially when it comes to medically compromised patient, you know, we're giving a lecture of how to manage the patient and when to refer. And most of them you can do. We have them all as undergrads. We did treat these patients. It's not difficult, but we have an extra blessing that you don't have. Welcome to join. If you have any question, I'm ready to answer. I really wanted to give an example of each category that we see, but because I respect the time and I don't want to interfere with my next lecture, I hope that was useful, just a bit, and you know what to get me for my birthday. Thank you very much for listening. And if there is any questions, I'm ready to take on the side or on the podium, as you wish.
Any questions?
Not saying this is an adult special need lecture, not a pediatric special need lecture, but we cross-match in the middle. Hello, Dictora. Well, once the patient's 12 and 1 day, believe me, they're referring to us directly. So we see the patients after they finish their time in pediatric, they refer to us directly in the centers.
How can we help with the transition?
We just refer the patient with his fine. We have it already, it's been done.
But
Yes.
do you need their notes, their medical records, the things we have, the medical clearances, anything we've done, or you just refer the patient to you guys?
Say again, sorry.
Do you need their file, their dental file from us?
Yes, if they have already the dental treatment done in a file in the dental department in pediatric, of course we're going to have the file. Not to start from scratch, right?
Thank you very much, Dictora. Very pleased to have you here.
Thank you so much. Thank you. Thank you.
Now for our next talk on dental anomalies in pediatric dentistry, which will be presented by Dr. Faisal Askari. Dr. Faisal is a specialist in pediatric dentistry and special needs. He obtained his BDS from October 6th University. He has a master's in pediatric dentistry from King's College in London and a membership in pediatric dentistry from the Royal College of Surgeons of Edinburgh. Dr. Faisal was invited to give many lectures for the Kuwaiti Board of Pediatric Dentistry and Kuwait Board of Advanced Dentistry. Please welcome Dr. Faisal Askari.
السلام عليكم يعطيكم العافية. Thank you, Dr. Munira. I remember reading the Royal College guideline on cancer for the first time. I felt miserable reading it. It's a never-ending story of guideline. Okay, so we're going to start talking about my topic is dental anomalies in pediatric dentistry. Okay, so we're going to talk simply about tooth development and what disruption can happen during the development of the tooth, and then you have a simple mind map going through the child development. Okay, so first we're gonna talk about the initiation bud stage, where if you have a disruption in this stage, you will have hypodontia or supernumerary, whereas the cup stage, you will have cyst, gemination, dens and denta. And then the bill stage, there is a different bill stage types, whereas you have histodifferentiation, where you have an amelogenesis imperfecta and dentinogenesis imperfecta. And then the morphodifferentiation, where you have size and shape anomalies, such as pig laterals and macrodontia. And then the opposition will have a hypoplasia fluorosis, dentin dysplasia, and hypercementosis. And lastly is the maturation stage, where you have a hypomineralization and fluorosis and tetracycline staining. And then the main complication of dental anomaly is aesthetic concern. It was a hot topic for the MP's questions. Most of the MP's questions were aesthetic concern. And you will have patients come to your clinic complaining of their aesthetic, then been bullied in school, they can't perform in the school, and then after that you have some eruption problems, where you have ectopic teeth, teeth that's unerupted, where you have a supernumerary, hypodontia, and then malocclusions, especially with AI patients. You have an open bite, a skeletal class 3, and then also you have a periodontal diseases. Okay, and that's all these factors will come that the patient will be, his behavior will be affected. His caries level will be very high, so you will have more difficulties dealing with these patients. Okay, so the first topic is hypodontia. Okay, it can be genetic, non-syndromic, or environmental. Okay, the most common tooth to be missing is the lower 5, which represent 3% of, excluding the 8, it's going to be 3% of the whole teeth, and then maxillary lateral incisors, and then the upper 5s and the lower centrals. And it can be associated with syndromes such as ectodermal dysplasia, Down syndrome, and such on. So the management, it depends when you see the patient. Is it in the early stage? Is it after he had some GA, or he has some multiple treatments done before? So your main focus should be prevention. Okay, you should maintain as many teeth as you can. Okay, you'll try not to extract more teeth. You'll try to restore more teeth, but there are certain difficulties going through the treatment. And then you can do some removable dentures, composite build-ups, orthodontic treatment, where you will do some interceptive extractions, or no, you have to liaise with an orthodontist and restorative dentist. And then moving on for the first case in this presentation, this case came to the clinic. They didn't say anything except they are missing a front teeth where they had trauma. And then while doing the OPG, you can see multiple missing teeth, lower 5s, upper right 5, and the canine. And while going through the history with the patient, they had, the father was a case of hypodontia, and the grandmother as well. So you can see some sort of link with the hypodontia patient. And again, if you can see the upper 6s, the position of the upper 6s, they are ectopic in position, but still quite early. You have to give the dental development a time to develop. And in this stage, you have to build a rapport relationship with your patient. Okay, you don't want to lose the patient behavior going through, because this patient needs multiple treatment, multiple sessions with you. So my approach is to keep it as simple as possible and just focus on your preventive measures. Okay. The second case, he came to our clinic. He had previous GA. He's a Down syndromic, and you can see that the lower right six been extracted before. And then you have a dilemma here. Would you keep the primary teeth? Would you extract the sixes? What would you do? So again, you have to think about the future of the patient, how many sessions, the dental treatment sessions, how he will behave going through his dental treatment. And then this case done by a colleague of mine in the UK. His chief complaint was a diastema, spacing, and missing lower centrals. And he came to the clinic complaining that he's been bullied in school. He don't want to go to school. And then what's the different approach? You can do wax up, you can do a composite build-up, you can do removal denture. So again, the approach should be to keep everything as simple as possible. You can see some gingival enlargement in the upper central area. And then these are the post-op. You can see how good the oral hygiene became. You can see the aesthetic of the patient. The patient became very, very positive going through the treatment, very positive on his school, and they built a really good relationship with each other. Going through to supernumerary, you have to know that males are more affected than females. It can be associated with genes, or it could be sex-linked. And there are certain syndromes linked with the supernumerary, such as cleft lip and palate, clavicular dysplasia, and Gardner syndrome. And the most common area is the anterior area of the teeth. Okay, so you can classify it onto the morphology on the location. So you have the most common supernumerary is the conical, which represents 75%, and then tuberculous, supplemental, and odontomas. And then when you classify it in the location, it's in the mesiodense, parapremolar, and paramolar area, and distomolar. And then the complication. You can see in this X-ray that the upper left one is displayed and rotated. Okay. It can prevent the eruption of the central, which is we see it a lot, and there is a guideline by the Royal College of Surgeons. And then it can cause crowding, it can cause aesthetic problems, it can cause dilacerations and root resorption. And whenever you have a supernumerary and the central are affected, you have to do sensibility test. You can take CBCT to confirm your diagnosis. And the management, it depends if the patient has complication or no complication, okay? If no complication, you can monitor, but you have to inform the patient that a cystic change can happen, and we have to keep a close monitor with the patient. If the patient is complaining of there is aesthetic concern, if there is a pain from the upper anterior region, if there is some discoloration from the tooth or preventing the tooth from erupting. So it depends how deep the supernumerary is, how it's aligned, and where you're gonna extract it surgically or simply. And you have to decide when to approach. You have to think about the potential resorption. If you have an uninterrupted maxillary central incisor, you have to think about when to interfere. So you can have a potential eruptive of the incisor, but if you go too early, you will damage the tooth itself. So you have to think both ways for this patient to have a better outcome. And whenever you extract the supernumerary, there's a potential to up to 18 months that the unerupted incisor will erupt within 18 months. But there is some certain things that you have to consider where you have to put a gold chain or not. Okay? And then this is a case where you can see there is an inverted supplemental. I don't think it's very clear. Preventing the upper left one to erupt. So you have to think both ways. When to interfere? Would you put a gold chain or not? The Royal College always prefer to advise to put a gold chain for a good practice to prevent second GA, prevent if you wanna let the central incisor erupt or no. Okay. And then amelogenesis imperfecta is a hereditary condition that affects the structure and the appearance of the enamel. There is some associated anomalies with the AI, such as anterior open bite, class 3 malocclusion, torotendism, and pulp calcification. Classifying the AI is going to be very challenging because the first 4 pictures, they are hypoplastic, okay? And the lower left pictures, they are hypomineralized. And then you can have a hypomineralized, hypoplastic manifestation in one tooth, okay? So it's very difficult to classify the AI itself, okay? And then you can see in the hypoplastic there is a rough pitted enamel in the first picture, whereas a hypoplastic with anterior open joint. And then picture C, you can see a horizontal banding of hypoplastic enamel. And then for the hypodenture, you can see some snow-capped enamel, and it can be associated with hypoplastic as well. So it's very challenging to have a definitive diagnosis. And in order to have a definite diagnosis, I prefer to have this as my guidance. So you have to have the mode of inheritance. So you have to do a genetic test, which is very, very expensive. The second is the medical and family history, and then the clinical and radiographic radiograph. And last is the molecular defect and biochemical defect. And you can assess that if you have a exfoliated primary teeth, you can send it to the lab, and then they will send you back the lab result. And then AI can be by itself or associated syndrome. So the first syndrome, trichodentoosseous, is a subtype of ectodermal dysplasia that the bone is affected as well, and they have a AI manifestation dentally. And then you might have some referral from the nephro department or the ophthalmology department that the patient's also complaining of the appearance of their teeth. So you might have some referral from the other departments. Okay, so management. Okay, so prevention is the topmost things to do firstly, and then you can do microabrasion and certain type of AI, especially with the hypomature, and then you can do icon resonant filtration, vital bleaching, direct and indirect capping, and then for the posteriors, you can. It depends on the type of AI. Okay, you can do a stainless steel crowns, gold onlay, and then assemble restoration. Okay, this is a case of mine that's been treated in the UK. Patient as well came with a static problem. As well, he can't perform the school. He's complaining of the shape of his teeth. So we started with the microabrasion. We give the patient a time to see the effect of microabrasion. The patient is not satisfied with the outcome. Okay, so we did some resonant filtration. The thing with resonant filtration is can relapse, okay, and it make the enamel very rough. So you'll have more plaque accumulation. The other treatment that you can do is bleaching and then composite. For his sixes, he had hypoplastic sixes, okay, and he complained of sensitivity. So we tried to deal with the sensitivity. You know, it's very hard to numb these teeth and do a proper composite restoration or a proper salicylic crown. Okay, this case has been seen by the Kuwaiti Board of Pediatric Dentistry and by Dr. Jarrah Al-Kandari. Okay, you can see how hard it can be, how aggressive it can be. This is a hypomineralized AI case. You can see the posterior teeth are within the gingival margin. We can see that he has a certain type of malocclusion. The thing is, they couldn't examine the patient. And then you can see the centrals and laterals, they are hopeless. They might be extracted angel anesthetic, they might not. So they want to do a simple operation in case they extracted the centrals. They couldn't, okay? So they spent 3 hours treating this patient, okay? They did a root canal treatment for the centrals and laterals. They extracted all the primary dentition and all the 6s. In hope of that the 7 will come and they will have a better relationship, a better behavior of the patient. And this is the patient after treatment. Okay. Lastly is dentinogenesis perfecta. It's a disorder mainly in the dentin. Okay. And it's affect the primary dentition more than the permanent dentition, because the ratio between the dental and the primary more than the enamel, more than the permanent, sorry. And then shield calcified into 3 types. Type 1 with osteogenesis imperfecta, type 2 is isolated, and type 3 in a certain people were mainlined in the States. Okay, so again, the management and the DI it's very challenging. Okay, because no matter what you do, you will have some wear off, some attrition of the primary teeth. So you have to keep the patient with a close monitoring. Okay, and the earlier you diagnose the patient, the better outcome. Okay, so you have prevention. You might cover all the back teeth. You might do some composite restorations, and then go on. Okay, this case you can see the patient in his primary dentition. Vertical dimension is lost. You can see a supernumerary and the palatal area. Okay, so what would you do? Would you put the patient to be treated under general anesthetic, or would you monitor the patient, or what? Remember that some patients with DI, they have osteogenesis imperfecta, so they might be on bisphosphonate. Okay, so you might liaise with his physician to know what you do. And the thing is not a 1 supernumerary, they have 2 supernumeraries. Okay, so you have to have the timing right. Okay, and you can see some radiographic features of the DI. You can see bulbous crown, there is cervical concentrations, the primary teeth are without pulp. Okay, so this is my presentation. Thank you.
Thank you, Dr. Faisal, for the informative lecture. And now we will welcome any questions from the audience.
Thank you for your presentation. I know you touched a little bit on it on the presentation in regard of genetic counseling, but how we can differentiate between AI, DI, and MIH based on clinical presentation?
So first you have a rapid history of the patient. You know the family history. There is some members of the family have the same dental manifestation, which can assist you in helping to diagnose AI. Whereas the MIS, there is a certain patterns affect more of the molars and the centrals. And again, when you ask a questions for the parents, there is the first 3 years of the patient's life, they may have some infection. The pregnancy wasn't going well, so it's mainly about the clinical appearance of the teeth, and then your question for the parents.
Any other questions? Okay. Thank you, Dr. Faisal.
يعطيك العافية.
Last lecture for this session is pulpal management of the traumatized permanent incisors. Where are we up to? Which is presented by our valuable speaker, Professor Sundus Al-Badri, who has kindly accepted our invitation to join us for this year's KDC. Professor Sundus Al-Badri is a professor and an honorary consultant in pediatric dentistry at the University of Liverpool and Alderay Children's Hospital. She has graduated from Jordan University in 1997 with a PDS and completed her PhD from Queen's University, Belfast in 2001. Professor Sundus is the School of Dentistry Vice Dean for Research and Postgraduate Studies. Her research is focused on clinical and patients-reported outcomes. She has research collaborations in dental trauma, prevention, behavior change, and inflammatory diseases in children. Prof. Al-Badri has published and co-authored many peer-reviewed publications, and more recently published a textbook titled Pediatric Dentistry for the General Dental Practitioner. Professor Sundus is the past president for PSPD, that's the British Society of Pediatric Dentistry, and the current chair of the Tri-Collegiate Membership Examination in Pediatric Dentistry. She's a member of the Royal College of Surgeons England faculty and Dental Surgery Board and chair of its research committee. She is also a member of the EAPD, European Academy of Pediatric Dentistry editorial committee. Please welcome Professor Sundus Al-Badri.
Thank you very much. Can you hear me? Yeah. We have no clicker. Anybody has the clicker for the... The clicker went missing. Thank you. Thank you very much for inviting me to speak here today. It's always a pleasure to be in Kuwait, actually. I get treated like royalty when I arrive here, so I really enjoy it. And I've just been watching all the lecture, and I just want to congratulate you all for your hard work and for an excellent healthcare system that you're developing and programs. You know, I've seen one of your trainees. I see all of you, you get the passion to help the patient and build it. And I can tell you, I think you should be very proud. I think it's a really high quality care system that you've actually put together. So thank you. So some of you might have heard this talk before. I tried to update it and do some changes, but I'm going to talk about the pulpal management of the traumatized permanent incisor and where we're up to. So a little bit on the update and what is going on. Okay, so I traveled yesterday from Liverpool, and a lot of you might know the United Kingdom. So Liverpool is at the north of the United Kingdom. I'm quite lucky that I work in both the University of Liverpool, which what we call a red brick university, and also a very modern children's hospital, which is one of the newest children's hospitals and one of the biggest in Europe, which is Alderhay Children's Hospital. Before I started my journey in Liverpool, though, I studied dentistry not far away from here. I grew up in Baghdad until I went to university in Jordan. I then went back to Belfast and I did my PhD at Queen's University in Belfast in Northern Ireland. I did my specialist training in Manchester. I know there are some Manchester graduates here, so I do have a link to Manchester, and had my membership and fellowship from the Royal College of Surgeons of England. I'm quite lucky now. I've been elected by members of the Faculty of Dental Surgery, and I'm now the chair of the research committee at the Faculty of Dental Surgery. So that's a little bit about my journey, just to put things into context of where I started my journey with dental trauma. I'm going to try to cover the following learning outcomes during this talk. I managed to get some extra time, actually, but I'll try to stick to time. Going to talk about the role of vital pulp therapy in the management of traumatized teeth, and then hopefully talk about the current management of the non-vital traumatized teeth, and then discuss the effect of pulp management on the outcomes. The lecture will be an outline. I'm going to talk about vital pulp therapy because for me that's really important. Our main aim when we're actually managing dental trauma, and we had a lot covered on dental trauma initially, our main aim is to maintain the vitality of the pulp, especially when we are treating young children, but it also applies to adults as well. The main aim is to maintain that vitality of the pulp. So I'm going to spend some time talking about the vital pulp first. And then we're going to talk a little bit about the non-vital pulp and the latest update and what is going on. So, how does the dental trauma affect the pulp? It can be either direct or indirect. So your direct is when you have a fracture injury and you have a pulp exposure. It's very simple. You can see the pulp, it's affected directly. Indirectly is if you have other injuries, or an avulsion is also a direct injury because the pulp will be cut from the apical area of the tooth. However, there are indirect damage to the pulp from all other injuries that actually affect the tooth. So you just need to look at it, and every traumatized tooth will have a compromised pulp, I would say, and it will heal in one way or the other, really. So let's start with the vital pulp and the management of the vital pulp. And the simple one we're going to talk about is what is the aim of that treatment. So as I said before, the aim is to maintain the vitality of the pulp and to have a continued root development. And I know when we talk about permanent incisor or permanent teeth, we talk about mature or immature. I would tell you that majority of children will always have an immature tooth because it's not just about the development of the apex, it's the actual development of the tooth. So a young tooth will always have a wide canal, will always have thin dentinal walls, as opposed to a mature tooth when there is further maturation and further thickening of the dentine. So there is always that issue in younger patients is even if the tooth have a closed apex, you're always want to maintain the vitality and continued root development. In much younger patients, if they have open apex, then you want to really aim to achieve apical closure and also further tooth maturation, as I said before. So the simple injury first is a crown fracture. And the message really, if you have a crown fracture, if the pulp is not exposed, so it's uncomplicated crown fracture, always cover the dentine as soon as you can. Even if your patient is not very cooperative or you don't have a lot of time, just put a very thin layer of composite ideally, and then maybe refer them to your pediatric dentist if you're a general dentist, or arrange for them to have sedation or other treatment, but always attempt to cover that dentine. Because if you don't cover that dentine, there will be bacteria going into the pulp might end up being compromised, and you'll end up with pulp necrosis. And we don't tend to do lower incisors endodontics a lot in children. I'm seeing more and more of those coming to us now, especially after the COVID pandemic when people didn't have treatment. They had enamel and dentine fracture on their lower incisor, the children, and because nobody has covered the dentine, they have difficulty. In the UK now, one of the biggest issue we have is access to dentistry, because the NHS dentistry is quite not in a good state, and basically patient can't get to a dentist to get the treatment done, and therefore they're coming to see us too late when they actually have an abscess on the tooth, and from a very simple injury that could have been managed initially very easily. So if you have a crown fracture, if any message you're going to take today, please do a dentinal coverage, because that's quite important. Things get a little bit more complicated when you end up with a pulp exposure, because then you're going to have to worry about what do you do. You start having options when you have a pulp exposure. And the options we have is direct pulp cap and a pulpotomy. And I'm going to talk about, oh, I pressed the wrong button. Yeah. So what do I do? Just press the same button again. Oh. Sorry. Oh, I'm gonna go back. No. I've lost it. I can't get back to where I was. Where was I? Here we go. Direct pulp cap. So when do we do a direct pulp cap? We do direct pulp cap if we have a small exposure. So 1 to 2 millimeter maximum exposure, do a direct pulp cap. And it needs to be recent. And by recent, I probably say within the first 24 hours from the injury. Anything more than that, you will have bacteria entering that pulp, and therefore a direct pulp cap is just going to cover that bacteria, and you might end up needing to do further treatment later on. And we know that direct pulp cap works from evidence from the 80s, so we don't need to, do a lot more work on it. We know it works if you get a really good seal. If you don't have a good seal, if you have a problem with cooperation, then things might change and the outcome might change. The next option will be the pulpotomy. So a pulpotomy is for any exposure size. So you can do it for 1 millimeter, or you can do it for 4 or 5 millimeters exposure. So whatever the size of the exposure, you can do a pulpotomy. Delayed presentation. So if they're coming to see you after 24 hours, then I would always do a pulpotomy. And the way I teach my undergraduate, actually, I always say to them, if in doubt, especially with an immature tooth, if in doubt, do a pulpotomy. If you're not sure, is the direct pulp cap is going to work, or I do a pulpotomy, you're probably better with a pulpotomy, because in a pulpotomy, you remove a couple of millimeters of the pulp, you remove all the infected pulp, and you make sure that you achieved healthy pulp. And I'm going to talk a little bit about the technique in a minute. And again, that's been known as a SVEC pulpotomy because it was first described by SVEC in 1978. It's developed now, and some people talk about partial pulpotomy and complete pulpotomy. For me, I would normally, especially in traumatized teeth, remove the pulp until I reach healthy pulp is what I'm looking for and what I want to achieve. So the success rate depends on all the damaged pulp removed. You have a lining on a healthy pulp, and you are getting a really good seal. So the seal is really important in this case. And the outcome that we want from a pulpotomy, for the tooth to remain symptom-free, for the pulp to remain vital, and for us to have continued tooth maturation. And I'm going to show you a few cases of how we can achieve that. We have more recent evidence. So the most recent is being published in the International Journal of Endodontics on pulpotomy for treatment of complicated crown fracture and permanent teeth, which is a systematic review. And the outcome is, as many systematic reviews tell you, we need more evidence. But basically, it does work and it can be successful. And the success rate can be actually varies between 75 to 96%. One study has compared it to direct pulp capping, and they found out that pulpotomy has a better success rate. That's probably because the direct pulp capping was not done on the teeth that was indicated for a direct pulp cap, because it might have been done on teeth that had bigger exposures or which had a delayed presentation as well. So the evidence is pulpotomy does work, and please, if you are in doubt, always do a pulpotomy. Clinical technique haven't changed much, really. You give local anesthesia. Isolation is really important. Ideally, you want to be placing a rubber dam all the time. You then amputate a couple of millimeters of the pulp. And then you put a cotton wool plunger with saline. Now, there is a lot of evidence and a new talk about the use of sodium hypochlorite. Now, endodontists always talk about pulpotomy and the use of sodium hypochlorite, but what they're talking about and the cases they usually describe is caries cases, not dental trauma cases. So, I don't think there is any evidence that saline or sodium hypochlorite works better or worse. So I say use your judgment. If you get really good cooperation, if you get really good isolation and you feel confident to use sodium hypochlorite, use it. If you don't have access to it, don't stop you from using saline, because actually the pulp affected by dental trauma, it doesn't have the same contamination and the same bacteria as the pulp our endodontic colleagues are talking about, because that is a pulp that has been exposed to a long caries process. And when they talk about it, usually describing it in molars teeth when they actually describe that. Then once your hemorrhage ceases, if it doesn't cease, remove another 1 or 2 millimeters of the pulp until you actually reach a healthy pulp. Then you put your lining material. Some people still use calcium hydroxide lining. It does still work. But if you have access to bioceramic, I would recommend using a bioceramic material. If you're using calcium hydroxide, always make sure you have a layer of glass ionomer cement over it, because what you want is that good seal, and unfortunately calcium hydroxide doesn't provide that sealing ability. The other bioceramics do, but calcium hydroxide doesn't. And then acid etch and a composite on the top of that as well. So this is a case I treated a long time ago, actually, in Manchester when I was training, and this boy actually attended. He had an injury on Saturday, and he didn't come to us until Tuesday, so it was 4 days later, and he had an the dentist said he had an intruded upper right central incisor. But we took radiographs and we looked at the CEJ junction between the upper right one and the upper left one, and there isn't actually any difference. So my conclusion was this is a partially erupted central incisor, and the diagnosis is complicated crown fracture, enamel and dentium fracture with pulp exposure. Now, I'm talking in the early 2000s, so we used to use calcium hydroxide at that time, and the teaching actually, if you have a delayed presentation, you should do a pulpectomy. But at the time we felt the tooth was so immature. If we're going to do a pulpectomy, how are we going to restore this tooth? What are we going to do with it afterward? Because it's not fully erupted yet, and it's not going to erupt any further if it doesn't continue to have root development. So we've decided to go for a pulpotomy, and what we call at the time a complete pulpotomy. So we removed the coronal section of the pulp. We put calcium hydroxide, glass ionomer, and composite at the time of the emergency appointment. And then 18 months later, you can see that the tooth is continued to develop. And that is simple calcium hydroxide, glass ionomer. And actually, I can then see more enamel, and I was being able to build it up and restore it properly for the patient. So I think if you have a vital pulp, it's always worth giving things a go. and try it. So don't rule out a pulpotomy if you have a vital pulp. And this is just to remind you how the tooth was at the start of the injury. So the latest evidence we have, this is a study, not very recent, it's now 6 years old, but this is a study when people compared pulpotomy versus direct pulp cap, and they even looked at cases of delayed pulpotomy. So a patient came to see you, you only had 5 minutes, the patient was uncooperative, and the only thing you can do is put a coverage of glass ionomer on the tooth and do a direct pulp cap. You then find a sedation slot 2 days later, and you bring them back to restore the tooth, and then you remove your glass ionomer and thinking, actually, I should have probably done a pulpotomy at the time. You can still do that. If you have a vital pulp, you can still do that. Even a week later, you can still do that. So if you're in doubt and you're not sure about the initial management, if it's a patient that referred to you from an emergency service somewhere and you weren't sure how the patient was initially managed, you disagreed with the management, you can still do the pulpotomy later on. There's evidence that that will also work. So we said about what other materials we can use. The first material we used was a ProRoot MTA when it first started. This is a closed apex tooth. It was done with MTA. There is a problem. This tooth is crowned and you can still see the gray line in the tooth. So whatever you do these days, do not use a bismuth oxide-based bioceramic on a vital tooth, because if there's nothing you can do with the discoloration, bleaching is not going to quite work. The tooth is still vital. So yes, this is a case when we treated it with white MTA when it first came to the market, but I probably won't do that anymore. And I don't need to do that anymore because there are so many other materials I've developed. We tend to use the putty material. We find it quite easy to manage. It's also zirconia based, the radio opacity in it, and it works really well. So this is another case about delayed presentation, and this was a patient who attended their general dentist with enamel and dentina fracture with pulp exposure. The dentist, actually we weren't sure about the pulp exposure. The referral did not mention the exposure. The dentist managed to put a temporary restoration, but the patient was uncooperative for any further treatment, so they referred them to us. It was seen on the normal clinic, is seen under inhalation sedation. Every time they numb the patient, they try to get near to the patient, he won't allow them to do any treatment. So he was listed to have treatment and to have pulp extirpation and root endoclosure under general anesthesia. So I turned up on my morning list. I haven't seen the patient before, turned up on my morning list, saw the patient on the list, and I went to take the history from the parents, and it was very clear that the tooth is still vital. It's still sensitive to cold. Actually, the patient had local at every appointment when they had inhalation sedation. They managed to get to the local anesthetic stage, but the tooth was really sensitive, and that's why they couldn't get to it. So I said, okay, we're going to have to move you, put you the second on the list, and we're going to have to do some x-rays now to see where we're up to. So we took a 6 months later x-ray on the day of the GA, and it was very clear that this tooth is still vital, it's still forming, it's still developing. So I then went and spoke to the parents, and those of you who trained in the UK, we always talk about being radical under general anesthesia, don't we? And we'd always say we need to do the most radical treatment. But I just felt if that was my child, I want this tooth to still remain vital, and I just think this is a risk worth taking. So I went and spoke to the parents and said, look, I don't want to do root canal treatment on this tooth. I want to give it a go and do a pulpotomy. If the tooth continues to bleed and I can't get to a healthy pulp, I will stop. But there is a chance that this might flare up and we might have to come back. And they said, yes, that's fine, we'll do that. So we went in theater, we removed the pulp. We actually were just below the CEJ. We managed to eventually get to a healthy pulp, and we used the bioceramic putty. We call it, in total fill in Europe, I think it's called Indosequence in the state, and I don't know if you get it or not in here. and then that was a year later. So it did pay off and it did work. And actually, if now it's flared up, it's okay because we've got a tooth with a closed apex, but the tooth is still asymptomatic and the patient is still doing well. And that has changed a lot. I would have probably not done that 10 years ago, but our understanding of the pulp, our understanding of the ability of the pulp to regenerate, it is changed. And therefore, I think even if you go below the CEJ, I think you should give it a go. If you have vital pulp, then you should try and maintain that tooth as much as you can. And again, more systematic reviews is formed, and that is by group which based in Monty Dougal and his group, and they looked at the pulp treatment of traumatized permanent teeth. A systematic review looked at all vital pulp therapy, and they compared materials as well. And basically what they're saying is complete pulpotomy seemed to have a better success rate. Although calcium hydroxide was the main pulp capping material, it still had a good comparable success rate to other materials. So use it. I didn't mention biodentine here. Do you get biodentine in Kuwait? Yeah. I find biodentine very helpful for vital pulp therapy in posterior teeth. I find its handling on anterior teeth a little bit tricky. That's why I don't use it. It's just I don't like the way it actually handles, and I prefer the way the putty material actually handles under that. Okay, so this is the simplest injuries. We talked about crown fracture with pulp exposure. What then if you have a crown and root fracture? So a little bit more complicated. And this is an adult patient, I think it was 18 years old, and these are not my photographs or my treatment. Some of you know I'm married to a restorative dentist and endodontist, Professor Fadi Jarad, and this is part of his work. So this patient turned up and they had crown root fracture of their central incisors, still quite young, would like their tooth if they can to maintain it. So they put a rubber dam and they removed the fracture bit, extend a little bit subgingivally, as you can see, and they had a vital pulp, so they did a pulpotomy. They couldn't quite reattach the fragment, so they ended up doing build up with composite, and I think they ended up doing some surgery on that tooth to restore it properly. But if the tooth is vital, then do a pulpotomy, and it doesn't matter if it's an open apex or a closed apex anymore. We now know this treatment does work. So just an example, if you see an older patient and they have this injuries, pulpotomy is still a possibility and can work. So the next injury is crown root fracture. What do you do? How do you maintain, how do you manage the pulp when you end up with root fracture? And you need to think about what factors affect the prognosis of a root fracture. So there are main factors that affect the prognosis is the position of the fracture line. So the more apical the fracture line, the more likely for the tooth to heal. The more coronal it is, the more contamination it will get from the mouth and from the crevicular fluid, and the more complication you will end up with. If there is displacement, that is also plays a factor. So if there is only clean fracture, it's more likely for it to heal with what we call either hard tissue healing or fibrous tissue healing. If there is a displacement, then you might end up with damage to the pulp at the area of displacement, and then you end up with what we call granulation tissue healing, or basically having an infection because you end up with a necrotic pulp. And also the stage of root development. The more immature the tooth, the more likely for it to heal better. The problem with immature teeth, if they don't heal, they are more difficult to manage, but usually they tend to heal better. And actually, it's a waiting game. All what you have to do is be patient. So in a root fracture case, be patient. I do a trauma clinic every other week. One of the reasons why I couldn't come easily with a direct flight from Manchester, because I had a fully booked trauma clinic. And we have the endodontic postgraduate who come to us to do some endodontic treatment on children during the trauma clinic. And they're very good in their skills. They get excellent skills. They're second or third year. The main problem with them is they just want to jump in and do treatment. They just want to open teeth and root treat them because that's what they do. Endodontists just like to do root canal treatment. And I spend a lot of my time every day telling them to hold off. Things that do sometimes heal. Children heal much better than adults, and sometimes you just have to wait. So I would say to maintain the root fracture, you really need to just be patient. And I'm just going to show you some cases of good healing that happens. So that's a tooth with a root fracture, what we call mid-root, vertical root fracture. And you can see that it healed really well. Probably hard tissue, you might see a line still, so it's really difficult to differentiate between the hard tissue and the fibrous tissue healing, really. This is another case, so this is a little bit more severe injury. You've got displacement, you've got palatal luxation of the coronal fragment, but the tooth is immature. So again, I think I had a debate with at the time because people thought it might be better to just remove the coronal fragment and bury the root behind to maintain the bone level and the bone height. But I looked at it and I said, actually, let's reposition it. Let's see what we can do. So we did repositioned it, and it did 18 months older, just managed to heal. And this is not going to heal by hard tissue healing. There will always be separation between the two, but it's continued to mature. Both continue to mature. And obviously this was a really cooperative child that we managed to give them local anesthetic and reposition it. Things might change if not. On the last of the fractured injury, if you have subcrystal or cervical root fracture, I still receive some referrals asking me to remove the coronal pulp and do root canal treatment and bury the root behind. Now, the problem is how you are going to do a good root canal treatment and a good moisture control, because we know that in order for us to achieve a really good outcome from a root canal treatment, we need to do isolation and good moisture control. If you're working subgingivally, you're never going to be able to achieve that. You're always going to have bleeding in the canal. So actually, if the tooth is vital, it's probably better to do a pulpotomy and then bury it that way. And this is again a case that we had the pulpotomy and the tooth was buried, and you can see actually if this patient is ready for an implant, they have good alveolar bone because we left the root behind, and it will be much better. I've actually got 3 or 4 patients at the moment going who had cervical root fracture, who are not having any symptoms and just have slight mobility, and they are about 12 and 13 years old. And we've had a long discussion with them about the treatment options they want, and they actually chose to keep the tooth the way it is, because whatever else you're going to do, you're going to put them through lots of treatment, and actually it's probably better for them to have their tooth, even if it's a bit asymptomatic, until it gets to a stage when they're ready to have an implant, and then they can have the treatment. I'm not going to talk about premolar transplants now because these patients don't need it. So and we only do it if they actually need a premolar to be removed. So vital pulp, again, with the last few ones on the vital pulp, and then we will move to the non-vital pulp. So I think I'm okay for time. So this is a luxation injury, immature tooth, luxation injury, just like root fracture, just wait. Most likely what's going to happen is you're going to end up with pulp canal obliteration of pulp sclerosis. And this is not an issue. A lot of these teeth will remain vital. There's about, I think, 15% in Andresen textbooks talk about it becoming non-vital. Endodontists will tell you it's no problem these days finding a canal. They can find it under the microscope. Worst case scenario, take a CBCT and try to locate it. So don't worry about it. If you're an orthodontist and you've got a tooth with pulp canal obliteration, you just need to warn your patient that when you start to move the tooth, you might, and there is an academic risk that you might end up with pulp necrosis, because what people say is you're stretching the blood supply that is really thin to that tooth, and you might end up with pulp necrosis. But this is a sign of healing. This means that you actually have a vital pulp, and therefore it's really important to try to keep it going. However, I've talked a lot about luxation injuries and waiting for the pulp to recover. This is not the same if you have severe luxation injury or if you have a combined injury. So if you have a luxation injury and crown fracture, the chances of that pulp surviving injuries from both sides reduce significantly. And therefore, you might need to intervene and start root canal treatment early to prevent inflammatory resorption. Inflammatory resorption only happens if you have damage to the periodontal ligament and if you have a necrosis and a bacteria coming from a necrotic pulp. So going early to do root canal treatment will prevent you from having inflammatory resorption. And this is a case that one of my trainee at the time, she's actually a colleague now, she's Judy Humphreys in Liverpool, who had a patient who came to see us 3 days after the injury. The referral from the dentist said the patient had enamel and dentium fracture on both upper right central and upper right lateral incisor. We took the periapical radiograph initially, but we also usually take a standard maxillary occlusal at the same time. And if you look very carefully, you'll see the CEJ junction between the central and the lateral is much deeper than the left-hand side. And clinically, we were convinced there is something wrong going on with these teeth. And basically, these teeth were intruded as well as fractured, but the dentist built them up to the same length of the other teeth so it get masked. So it's really important to look at radiographs really carefully. And this is a case we managed orthodontically at the time because it was too late by the time they came to see us to do surgical repositioning. So we extruded the teeth orthodontically, and the minute we managed to get access to the palatal surface of these teeth, we initiated root canal treatment. We started pulp extirpation, and we dressed the teeth with calcium hydroxide at the time. You can probably just have a look at this radiograph here, where you can see the roots, and you can just about see some signs of resorption starting. And we actually managed to stabilize that. So if you again look here, you can see a bit of surface resorption here and a bit of resorption here. So we managed to stabilize it by starting root canal treatment early. So yes, I've talked about being cautious and trying to maintain the vitality of the pulp, but sometimes you need to intervene, and that's mainly if you have severe luxation injury like a palatal luxation or intrusion, severe intrusion, or if you actually have combined injuries, especially if it's really close to the pulp, then the chances of that pulp surviving. I've done a few pulpotomies on luxated teeth, and they come back with an abscess and root resorption. So I've learned my lesson really is, I think guidelines are guidelines, but if you have combined injury, you're better with starting root canal treatment than not. I was very lucky in 2019 in Cancun. I was asked to judge the Andresen Poster Prize, and I managed to meet the man himself before he passed away during the pandemic. So a lot of our evidence came from Andresen, but at the same conference he was talking about management of trauma, and he said, I know why pediatric dentists get better outcomes when they manage trauma, because you're very patient and you respect the pulp and the periodontal ligament. So that's probably the message I'm giving you today, is trying to just be patient and gentle and just don't jump into treatment unless you really need it. So we want to keep the vitality going. We want to maintain the vitality as long as we can, but sometimes that doesn't happen, and that is because we either see the patient late or due to the severity of the injury. If you have a severe injury, you will end up with a non-vital pulp. And most of the time, I'm not going to talk about routine root canal treatment because I don't think that's what you want me to talk about. I'm talking about now immature teeth that is becoming non-vital, and that's where people want to know what's the latest evidence and what we actually do. So these teeth usually have an open apex, have a very thin dentinal wall, and also have the crown to root ratio is not great, so they might end up with further injuries and further problems. And how do we define an open apex? This been defined back in the 70s as basically a size 60 GP that you can put through and you won't get any resistance. So if you can do that, then you'll probably have a tooth with an open apex. And these are photos courtesy of Professor Ian Mackey, who trained me in Manchester. And I don't think you can find these photos anywhere else these days. So I'll keep them there. So if you're as old as me, you might have remember what we call conventional calcium hydroxide epixification. I think these things are always useful because if you've been long enough in dentistry, you'll find out 20 years later the treatment that you were told to stop doing will become back in fashion. So don't discard anything you hear about. So that was basically, we used to dress the tooth with calcium hydroxide. We change it every 3 months until we have an apical barrier at the end of the open apex. These were the days before bioceramics and before thermal obturation. So we needed something to be able to condense the root canal again, the root filling against, and it had a good success rate. It was a straightforward technique. It can be used by dentists in remote areas if they don't have access to a specialist dentist. We didn't talk about discoloration a lot at the time, and actually we didn't have that many abscesses or recurrence of infection, and that's probably because we were putting an antimicrobial in these teeth for months and months. So the treatment took anything between 9 months to 18 months actually. So when I first trained in Manchester, when I went there, they were irrigating the teeth with saline. That was the treatment, and you can't ask for anything else on the clinic. Only thing you are giving as an irrigant is saline. You can't use sodium hypochlorite because they were worried about an incident, and that's all what they use. So I went back home and I was telling my husband that we're using saline. He said, saline? It will do nothing. Why would you use saline? But then I said, but it works. And he said, well, of course it works. You're leaving calcium hydroxide in the teeth for months, so you don't need anything else to manage the bacteria. But there were problems with it. One of them is, because we said we need to see the patient every 3 months, we lost so many patients to follow-up. They had no symptoms, never came back to finish the treatment after. We had no qualitative increase in the root dimension. The final filling was really difficult, and at the days then heated obturation became fashionable, but we couldn't that much use it because we weren't sure if we actually have a barrier at the end. And we know that the root can continue to be predisposed to fracture. However, I will put a big question mark around that because all the bioceramic we use at the moment, one byproduct of it is calcium hydroxide. So I don't think we can argue that calcium hydroxide or bioceramics are better than each other if you're putting them into the roots, because actually they will all continue to release calcium hydroxide. I think these teeth were predisposed to fracture because they are short, they have thin dentinal wall anyway, so they will have more root fractures anyway if you think about it. So then come MTA, and I'm talking about the initial version of MTA, the Portland cement a modified MTA, and it was the Pro-Root MTA we use, and it became very fashionable. It will give you immediate barrier. You can do it in 1 or 2 visits. Initially, we were doing it in 2 visits, putting a moist cotton pledget inside the canal to help the cement to set. In the UK, we don't do that. We always do it in 1 visit, and the argument is you've got enough moisture from the other end of the tooth to help the cement to set. And we had really good coronal seal, we had better outcomes, and we had improved compliance. We managed to finish treatment for the patient in 2 settings, and this is just how we initially did it. If you can have access to microscope, it's much better. We do 3 to 5 millimeter of a plug in here of MTA, then heated GP on the top, and then we restore it with composite after that. And this is some of the data that we looked at our one visit MTA, and if you compare it to what's published out there, it's the same success rate really for MTA if you do it over one visit or two visit. However, I must admit, I no longer use MTA with bismuth oxide for root endoclosure. It's very nice to handle. If you're a novice, it's very easy to manage into the canal. However, we have a problem, which is the discoloration. And even if you do it under the microscope, you will end up with some discoloration. And I don't know if you know, but in the United Kingdom, we stopped using tooth whitening on patient under 18 about 10 years ago, I think now. And this is due to change in the EU law about using tooth whitening on patient under 18. Although we're out of the European Union, our laws hasn't changed. We just adopted the same law, so we're still in the same situation. But since we stopped using MTA, we actually very rarely have children who require tooth whitening who had trauma. We've got more of the dental anomalies patients who require tooth whitening, but we stopped causing discoloration since we actually stopped using it. So there are alternatives which are Portland cement based and get the same feel and the same mix as MTA, but they don't have bismuth oxide in them, so they are quite good to use. Biodentine then came into the market in the 2011, I think, and we started to try to use it. And this is one of the first cases we used to do biodentine. Again, I don't find it very easy to handle. Therefore, we obturated the whole root with MTA, with biodentine, sorry. But you can spot a problem, can't you? If you're a general dentist, I've done this treatment and I've sent the patient to you and you've seen them and you took an x-ray, you will say, well, Professor Al-Badri didn't know what she was doing. She just put some calcium hydroxide in this tooth and she never finished the treatment. It's not radiopaque enough. It doesn't look like a root filling. You will then try to open the tooth to get into it. You'll find it full of dentine and you'll find it really difficult to access it that way. So I know Sheffield tend to use biodentine quite a lot in the UK for root endoclosure. We are not very big fans of using it for root endoclosure. We stopped using it for that technique, but it doesn't cause discoloration. So that's a patient who had an MTA in one tooth and biodentine in another, and you can see actually there is a very different in the discoloration between the two. So again, we use the other materials, and now we use the putty. We use the total fill, but the Neo putty is quite popular actually. It's the same company, Neo Smile, that makes the crowns, the zirconia crowns, but they also produce the bioceramics at the same time too, basically so you can do your pulpotomy before you put your zirconia crown on the tooth. So this is a case of root resorption. So this is if you didn't get to the pulp and extirpate in time. So this is a patient who probably had luxation injury and a fracture injury, and it was managed initially with a direct pulp cap. Then we knew that the patient needed root canal treatment because they had inflammatory resorption. We open the tooth, dress it with calcium hydroxide until the resorption is stable. Then we obturated the whole tooth with total fill putty. And that's another case of we actually did a plug, and this tooth had MTA, and you can see the MTA and then the root canal. This tooth has the putty, and if you actually look, it's difficult to distinguish between the GP and the total fill putty when it's actually into that tooth. Okay, so that is our management of open APCs at the moment, what we call root endoclosure or epixification. And the latest is really try to use a non-bismuth oxide based bioceramic, and then obturate with GP if you can. I can't do a talk without talking about Liverpool when coming from Liverpool, and I just want to thank Liverpool Football Club actually, because they've been, the Football Club Foundation been supporting us with the students to do community events, and this is a refugee hotel, Afghani refugee hotel in Chester, one of the cities outside Liverpool, and we actually went and managed to screen 170 children, and 50 of them travel now to the dental hospital to get treatment because they can't access a dentist. So I just want to thank Liverpool for doing that. So they're not only good for their football, they do other things as well. So lastly, I said I'm going to talk about regeneration, and I'm going to touch on it. I think I'll be on time now. So regenerative endodontics. It's basically biologically based procedure designed to replace the damaged structure, including dentine, root structure, and other cells of pulp dentine complex. And they are not new procedures. They were first described in 1961. Actually, regeneration via blood clot was first described in 1961. But then they found out it wasn't working very well, so they stopped using it. But then become fashionable again in the early 2000s, late 1990s. And people were talking about this shift, and we're all going to be doing regenerative techniques. And I thought by now, 2023, root endoclosure will no longer exist. We're all going to be regenerating these teeth. We're all going to be doing further root development and working on that. And this is our first study, and I'm only going to talk, there are different techniques of regeneration described in the literature. The bottom line is there is no evidence that there is any difference between one technique or another, and the most popular one is the blood clot one, which is basically you access the tooth, you disinfect it using, you can use calcium hydroxide. Initially, we were told never to use calcium hydroxide because it won't work, because it will kill all the cells, but it doesn't. And now the European Society of Endodontology recommend the use of calcium hydroxide as a dressing. You bring the patient back, and you then try to get some bleeding into the canal. Good luck to you. It's always described in the literature. You actually try to do it, and whatever you put, especially if you put the antibiotic paste, it used to eradicate all the infection, and you can't get any bleeding into the canal. And you start emailing some of the people in the state who actually written the paper. So we, Kenneth Hargreave and Martin Tropp, we emailed them to say, oh, you know, we can't get bleeding. I said, oh, funny you say that. We did notice that problem. They didn't actually put it in their papers, but basically they said, it doesn't really matter if you can't get a blood clot. It won't make a difference. But anyway, this is our first case that we did this technique for. It was back in 2010. It was a Denson Denti case. It wasn't a trauma case. Regeneration doesn't tend to work very well in trauma because you actually have damage to the periodontal ligament and to the stem cells. So we had the tooth initially. We did the regeneration, and we took this radiograph 12 months later, and we were thinking, wow, this works. We should really do that. And actually, on the basis of that, we designed a whole randomized controlled trial, which was one of my colleagues, Dr. Laura Garchor's PhD at the time. We did follow the patient up 5 years later, and this is what happens 5 years later. So can't see any of that root. Can see some apex forming here, but that was here. And if you really look hard, you can see that was there anyway. So I think that tooth must have had some root fracture somewhere, although there was no injury of, no history of trauma. We started to analyze what went there, and we thought, oh, maybe it's just the angle of the radiograph. Maybe here and here it was different angles. We didn't sort of standardize it, and that's why we can find root formation. I really think root resorption has happened in that time. So you had it then, you had some root formation, and then you ended up with more root resorption happening into whatever was filling that tooth. And I was in Helsinki in September. I attended the European Society of Endodontology, and they had a whole session on regeneration. They are developing something called S3 guidelines, and if you're not familiar with S3 guidelines, it's basically you start with a systematic review, then you get experts in the field to discuss it, and then you get people from different you open it for consultation basically for people. So you get pediatric dentists, you can get periodontists, you can get general dentists, you even get a member of the public to comment on it, and it's been an agreed and discussed guidelines. And the expert was presenting some of their cases from France, and they had exactly a similar case to this, when they actually had root formation and then ended up with root resorption afterward. We also had discoloration at the time. We were using triple antibiotic paste that had monocycline in it. But also don't forget, we were putting MTA that we told you is cause discoloration. We were putting it on the coronal part of the tooth. And then we also were putting, we are creating bleeding into the canal. If you get back to your dental anomalies, you can get, if you have bleeding, you can get hemosiderin. Hemosiderin can cause intrinsic staining. So we don't know which one is causing which. And this was our randomized control trial that we did. We had 30 teeth, 15 we had teeth, had MTA root end closure, another 15 ended up with triple antibiotic paste, blood clot regeneration, and there was no difference in the survival. Clinical success was great, but there wasn't really significant thickening in the dentine after the regeneration. And that was confirmed by another systematic review done by Monty Dougal's, Professor Dougal's group. Again, they didn't see that much change. The healing is great, but there wasn't a lot of change in the dentine formation. So where are we now? What should we do? You will be very pleased to hear that after attending the S3 session at the European Society of Endodontology, I have learned that 13 years later, we're none the wiser. There is no evidence that regeneration works. People are still working on it. There is a lot of proof of concept that is being required, and therefore, where we're up to really is we need to work and do more research. I think there is potential in the technique, but I think we're way early to adopt it as a clinical technique that we always use. It can be helpful, but you might end up with further pulpal disease. There are different techniques. There's always emerging problem, and we need further proof of concept. And this is one of our trial cases. This is one of our trial cases that we actually thought something has happened. So as you can see here, tooth was an open apex. This is the radiograph taken later, and this is closed apex. The patient was not happy with the color. So we thought about what we can do, and we thought, well, the only thing we can do is we need to open this tooth, go back to root canal treatment, treat it, and do internal bleaching. And that's what we actually did. And we couldn't find anything in that canal. It was hollow when we opened it. So whatever happened that caused that further root formation, it's not revitalization or regeneration, because actually the pulp is not regenerated, the tooth was empty. We have done the root canal treatment. We then did an internal inside and outside bleaching. We left the tooth with no composite. We told the patient, that he was 18 at the time, we said to him, you will need to make sure that we need to keep it that way for the bleach to actually work. And it did actually work once you do it like that, and we were asking him to top it up every couple of hours, and then he had composite buildup. And this is my restorative colleagues who did that, because the patient was 18 by the time we actually get to complete the treatment. So have we ditched regeneration? We don't use it at all. We actually haven't ditched it completely. We still use it sometimes. So it's not our first call. Our first call is root end closure. But if we have teeth like that, when they actually have very little root formation and there is nothing happening, we do tend to give it a go with the regeneration, because we feel otherwise that the patient is not going to have a really good tooth is left behind. So this is a case that we've sort of done regeneration form, and you can see actually there is some root formation happening in that tooth. However, what I've learned after a while is all what you have to do is be very gentle and respectful for the pulp. Remember when I said if you have a bit of vital pulp, just try to keep it. It goes again, if you go in to do root canal treatment and the patient is having a sensation at the apex, or you feel that there is a bleeding at the apex, you can stop as where you are and dress it with calcium hydroxide and do your root end closure up to that length. You don't need to go all the way to the apex. It's not necessary. This is a patient who actually had an abscess associated with an upper left one that was traumatized. We then dressed it with calcium hydroxide, and then he, I think it was COVID happened, and he did not come in for a while. So when he came in for a while, we took a radiograph and thought, actually, this tooth is continuing to develop, and we actually had a barrier beyond that calcium hydroxide. And then we have sort of decided to just leave the tooth be and put a bioceramic material in there. In hindsight, I would probably obturated it with bioceramic until here. I think at the time we felt, oh, we're going to try to regenerate the rest of the pulp, but I think the patient remained asymptomatic. But I think knowing more now and treated some more cases that came back with an infection, I would probably obturated it with a bioceramic here, up to here. This is another case, again, one of the COVID cases, so an avulsed upper right central, then it had an abscess and we accessed it, then we lost the patient. They came in April 2018. They came in 2019, but nobody thought, people thought that was the calcium hydroxide still in the canal, so they just opened the tooth and dressed it again. But then that what happened when they came after COVID in 2022, and I was like, this tooth is continued to grow, something is happening there. So we thought, let's get a CBCT and find out what is going on. And as you can see, it is full of bony material. It actually still have a PDL around it, which is very strange, but still have bone inside it, because somebody said, is it ankylosed? I said, no, it doesn't have an ankylosis sound to it, just look like it's full of bone. So again, we restore the access cavity with a bioceramic material and let it be. So sometimes regeneration does happen accidentally, and you just have to be watching for it and be careful with it. Last case, and then I will be finished. So this is a very recent case. This is Sam, who was referred to us to have root canal treatment of an immature upper left central incisor that became non-vital. There was delay between the initial consultation appointment and the first treatment appointment, and the patient had a trauma in the middle between these appointments. So on the day of the appointment, we opened the tooth, we estimated the working length, we worked with the apex locator as well, but remember, apex locators are not great with open apices because they don't have a construction, so it doesn't work very well. Then we took a radiograph after we dressed it with calcium hydroxide and thought, oh, our calcium hydroxide is a bit short. But then I looked at it and I said, yeah, but this tooth finished here and this tooth is finishing here. So surely something happened and there was some regeneration happened in the meantime. And I don't know if it's the trauma that is stimulated it. Was it vital? Was it non-vital? Me and my husband had an argument because he said to me that actually, no, it's not growing, it's just a different angle. And I said, no, but you can have a look here and here. Surely it's not the angle, surely it's continued to grow. And actually there was bleeding and the apex locator was stopping at that. So anyway, we left it for a while to monitor it and see what's going to happen. And then we felt that the root formation has sort of stopped at that. So this one I've learned, and I've obturated up to that length with a bioceramic material. But again, it's things, unexplainable things can happen. A lot of regeneration evidence was based on premolar and cases, and it could be that the morphology is very different. So, you know, just because one or two cases happened and the tooth continued to form, that doesn't mean that the technique is evidence-based and we should be adopting it as a main technique. But I guess, if anything, is just be gentle with the pulp. If you feel that there might be some vital pulp, give it a chance. There is nothing to lose from giving it a chance. And that's how it was initially. So I am convinced that it's not the angle. We do have some root formation and root generation. And that's me, really. I just want to thank my team. This is our postgraduate students that was in Maastricht, actually. And this is our endo course that me and Fadi run, endodontics in children. We run it in the UK every year around October time. And thank you very much again for inviting me. Thank you.
Thank you, Prof. Sundus. Does anyone have any questions? If you have any questions, just put your hands up.
Thank you for your presentation, doctor. I know you haven't touched in the presentation, but would you advocate for extraoral root canal treatment for avulsed teeth?
Yeah, this keeps coming in and out of guidelines, isn't it? Sometimes they say yes, sometimes they say no. I think you probably will be, I think it depends on the patient and what you're doing. So if you're doing it under general anesthesia, for example, and you're putting the tooth back, you're reimplanting the tooth under general anesthesia, so I would say yes, go for it, because the chances of the patient allowing you to do the treatment is very minimal. If the child is cooperative and you're doing the treatment under local anesthesia, then I would say probably not, because you will cause more damage to the periodontal ligament and possibility of more ankylosis trying to mess around and do root canal treatment extraorally. So I would say it depends on the case.
Any more questions? Okay, thank you very much, Prof.
Thank you.
Sundus. Dr. Anfalka. This concludes our session today. We will not have any lectures here until after the opening ceremony, but you're more than welcome to go to the other hall. There are oral medicine lectures there. Thank you very much.
أعوذ بالله من الشيطان الرجيم. قل الحمد لله وسلام على عباده الذين اصطفى. الله خير أما يشركون. أمن خلق السماوات والأرض وأنزل لكم من السماء ماء فأنبتنا به حدائق ذات بهجة ما كان لكم أن تنبتوا شجرها أإله مع الله بل هم قوم يعدلون. أمن جعل الأرض قرارا وجعل خلالها أنهارا وجعل لها رواسي وجعل بين البحرين حاجزا أإله مع الله بل أكثرهم لا يعلمون. أمن يجيب المضطر إذا دعاه ويكشف السوء ويجعلكم خلفاء الأرض أإله مع الله قليلا ما تذكرون. أمن يهديكم في ظلمات البر والبحر ومن يرسل الرياح بشرا بين يدي رحمته أإله مع الله تعالى الله عما يشركون. أمن يبدأ الخلق ثم يعيده ومن يرزقكم من السماء والأرض أإله مع الله قل هاتوا برهانكم إن كنتم صادقين.
مساء الخير وأهلا وسهلا فيكم جميعا في مؤتمر الكويت 23 في طب الأسنان. بالبداية خلونا نبلش بكلمة دكتور أسنان. منو كان يخاف من تجربة دكتور الأسنان؟ أعتقد الكثير. أنا عن نفسي كل ما كنت أذكر كلمة دكتور أسنان أو بزور الدكتور أسنان فكانت تجيني خلينا نقول الخوف أو كنت أخترع. أكيد كلكم مريتوا في نفس التجربة واليوم أنتوا اخترتوا هذا التخصص لغاية سامية ومهمة، وأنا متأكدة من ذكريات الأجيال الجديدة اللي راح تغيرون فيها الأجيال القادمة عن نظرة دكتور الأسنان. يمكن البعض يخاف وهذا شيء طبيعي، لكن وجودكم بعطائكم لعملكم قدرتوا تخلون هذه المهنة وتحسنونها في صورة أجمل. فشكراً لكل دكتور يسعى بأن يطور وينمي في هذه المهنة. حضورنا الكريم، في البداية خلونا نرحب في ممثل معالي وزير الصحة الدكتور أحمد العوضي، وكيل وزارة الصحة المساعد للشؤون الإدارية السيد عبد الرحمن الفارس، فيتفضل.
بسم الله الرحمن الرحيم. الأخوة والأخوات ضيوفنا الأعزاء، الحضور الكريم، السلام عليكم ورحمة الله وبركاته. يطيب لي أن أنوب عن معالي وزير الصحة الدكتور أحمد عبد الوهاب العوضي في افتتاح مؤتمر الكويت 23 لطب الأسنان، ويطيب لي أن أنقل تحياته وأرحب بكم وأحيي الأخوة والأخوات الضيوف في بلدهم الثاني الكويت. ويسعدني اليوم أن أكون بينكم في حفل افتتاح مؤتمر الكويت 23 لطب الأسنان. الأخوة والأخوات، يأتي انعقاد هذا المؤتمر إسهاماً ومشاركة ضمن رؤية وأهداف وزارة الصحة في مواكبة حدث التطورات العالمية بمجال طب الأسنان، والتي من شأنها الارتقاء بالجانب العلمي والعملي للكوادر العامة وتوفير مناخ من المعرفة وتبادل الخبرات مع نظرائهم في الوطن العربي وبقية بلدان العالم والتقدم المستمر في هذا المجال. ولا يفتني هنا أن أثني على فريق العمل لجهوده المبذولة في الإعداد والتنظيم لهذا المؤتمر لتحقيق أعلى استفادة وبالصورة المشرفة التي نرجوها جميعاً، فلهم مني كل الشكر والتقدير. كما يسعدني إلا أن أقدم خالص تقديري لجميع المشاركين الذين أسهموا بحضورهم وإمكانياتهم العلمية وخبراتهم العملية في وضع المؤتمر كتجمع علمي على هذا المستوى المتميز في مجال طب الأسنان. الأخوة والأخوات، الحضور الكريم، إن تحقيق تطلعات ملتقى خدمات طب الأسنان وتلبية احتياجاتهم والارتقاء بجودة الخدمة المقدمة لأفضل المستويات العالمية هو هدف أساسي نسعى إليه بالتخطيط والعمل والتطوير وتضافر الجهود، والذي يظهر جلياً من خلال ما تم تحقيقه من إنجازات في الفترة الأخيرة، ومنها على سبيل المثال الحصر التوسع في خطط الابتعاث بزيادة عدد المبتعثين للدراسات العليا الخارجية بمجال طب الأسنان إلى عدد 77 طبيب لهذا العام، إتاحة الفرصة لزيادة عدد الأطباء للالتحاق ببرنامج الدراسات العليا المحلية، برامج البورد الكويتي لطب الأسنان القائمة حالياً، التوسع ببرنامج دراسات العليا المحلي في تخصصات طب الأسنان باستحداث واعتماد 3 برامج جديدة في هذا العام، وتشمل برنامج البورد الكويتي لتقويم الأسنان، برنامج البورد الكويتي لعلاج اللثة، وبرنامج البورد الكويتي للاستيعاب الصناعي للأسنان. تم الانتهاء من ربط إلكتروني لخدمات بين مراكز طب الأسنان والمستشفيات العام ومراكز الرعاية الصحية الأولية. افتتاح وتشغيل مركز تيماء الصحي لطب الأسنان يحتوي على 18 عيادة موزعة على 6 أقسام تخصصية، والتي تمثل نقلة نوعية غير مسبوقة لخدمات طب الأسنان في محافظة الجهراء كأول مركز رعاية صحية أولية متخصصة بالكامل لطب الأسنان. التوسع بخدمات طب الأسنان في منطقة صباح الأحمد السكنية مؤخراً من خلال زيادة عدد طب الأسنان بمراكز صباح الأحمد الصحي قطاع A، مع توفير عيادات تخصصية لجراحة الفم المركز، وذلك توفير خدمة حوادث طب الأسنان لمنطقة صباح الأحمد السكنية للفترة الليلية كما كامل أيام الأسبوع، بالإضافة إلى افتتاح عيادة طب الأسنان بمركز صباح الأحمد قطاعي. الإعداد والتجهيز الافتتاح الرسمي خلال الأسابيع القادمة لمركز التخصصي لعلاج الأسنان للأطفال الجهراء، حيث سوف يكون المركز متخصص لتقديم طب الأسنان الشامل للأطفال فقط منذ الولادة إلى عمر 16 سنة في مكان واحد كخطوة مبدئية في الوزارة تمهيدا لتعميمها على باقي المحافظات خلال السنوات القادمة. الاستعداد لتشغيل وافتتاح مركز برنامج العاصمة المدرسي لصحة الفم والأسنان بضاحية عبد الله السالم 40 عيادة فور الانتهاء من أعمال التأهيل والتجهيز، ومتوقع خلال النصف الأول من العام القادم متابعة أعمال التأهيل والتجهيز لمركز صباح الأحمد التخصصي لطب الأسنان 41 عيادة تمهيدا للافتتاح والتشغيل، والمتوقع نهاية النصف الأول من العام القادم. ختاماً، أتمنى للمؤتمر النجاح والتوفيق وأن يخرج بالنتائج المرجوة، كما أتمنى لضيوفنا الكرام طيب الإقامة في بلدهم الثاني الكويت. حفظ الله الكويت وشعبها تحت قيادة حضرة صاحب السمو والبلاد الشيخ نواف الأحمد الجابر الصباح، وولي عهده الأمين الشيخ مشعل الأحمد الجابر الصباح، وسمو رئيس مجلس الوزراء الشيخ أحمد النواف الصباح، حفظهم الله جميعا. والسلام عليكم ورحمة الله وبركاته.
كل الشكر الممثل معالي وزير الصحة وكيل وزارة الصحة المساعد الشؤون الإدارية السيد عبد الرحمن الفارس. والآن حضورنا الكريم نرحب برئيس جمعية أطباء الأسنان الدكتور محمد دشتي، فليتفضل.
بسم الله الرحمن الرحيم، الصلاة والسلام على أشرف الخلق والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. مساكم الله بالخير جميعا. بالبداية أحب أشكر ممثل راعي الحفل الوكيل المساعد لشؤون الشؤون الإدارية السيد عبد الرحمن الفارس وعلى الكلمات الرائعة، وكذلك أتقدم بالشكر لرئيس جهاز المسؤولية الطبية الدكتور سلمان الصباح، ونشكره على دعمه الدائم وحرصه على الحضور المستمر. وأرحب بجميع ضيوفنا الكرام من مدراء ومراقبين ورؤساء أقسام ورؤساء الجمعيات السابقين والحاليين، وجميع العاملين على تطوير المنظومة الصحية في بلدنا العزيز. كذلك أرحب بضيوفنا الأعزاء من رؤساء نقابات وجمعيات طب الأسنان العربية، وأقول لهم حياكم الله في بلدكم الثاني الكويت، شرفتونا ونتمنى لكم إقامة سعيدة، سامحونا على القصور مقدما. في كل مؤتمر كنت أعيد وأشيد في مستوى قطاع طب الأسنان في دولة الكويت ومدى التطور والتقدم والخبرات والطاقات الفنية والأكاديمية التي تعتبر منافسة ورائدة على المستوى الإقليمي والعالمي، وأرجع وبكل فخر أشيد فيها مرة ثانية وثالثة، وراح تستمر دائما من أفضل إلى أفضل بإذن الله. ولكن اليوم واجب علينا أن نلتفت ونحرص على مواجهة التحديات والصعوبات التي تواجه قطاع طب الأسنان في الكويت، واللي بوجهة نظري أبرزها وأهمها عدد مخرجات زملائنا أطباء الأسنان الجدد التي يتعين علينا كلنا ممثلين بقياديي وزارة الصحة وعلى رأسهم معالي وزير الصحة والوكيل المساعد لشؤون طب الأسنان وجميع المسؤولين في هذا القطاع على توفير جميع الإمكانيات والحلول اللازمة للارتقاء بسبل التطوير والتدريب حتى نتفادى الظلم الذي قد يقع على هذه الفئة من الخريجين من قصور في حقهم بالتدريب والتعليم، والذي بدوره يترتب عليه وبشكل مباشر تدني مستوى الخدمات المقدمة لأبناء وطننا العزيز والمنظومة الصحية بشكل عام. وطبعا هذا لا يعفينا كأعضاء مجلس إدارة جمعية أطباء الأسنان الكويتية من إخلاء مسؤوليتنا والدور الأساسي المناط بنا بالمشاركة والتعاون مع إخواننا في وزارة الصحة لتطوير هذا القطاع والحفاظ على إبقائه دائما في أعلى المراتب إن شاء الله. مؤتمر الكويت لطب الأسنان 23 تميز هالسنة هذه والمرة الأولى بوجود بري كونفرنس، يوم علمي تخصصي في زراعة الأسنان، واللي تم تنظيمه بالتعاون بين اللجنة العلمية ورابطة جراحين اللثة في جمعية أطباء الأسنان الكويتية، فشكرا لكم على التنظيم الأكثر من رائع. تسجيل المؤتمر تجاوز 2000 طبيب عدد المحاضرين فوق 70 محاضر دولي ومحلي، بالإضافة إلى العديد من ورش العمل والبوستر برزنتيشن، علاوة على وجود أكبر معرض لطب الأسنان في الكويت. فشكرا للشركات المساهمة والراعية. قبل ما أختم، أدري أن تعودنا في كل سنة في افتتاح مؤتمرنا أن نتميز بفقرة فنية مختلفة، ولكن بالنيابة عن جمعية أطباء الأسنان الكويتية أحب أعتذر للجميع، حيث أن هذه السنة دعما واحتراما لظروف إخواننا في فلسطين نلتزم بعدم القيام بهذه المظاهر. وندعو من الله العزيز القدير الفرج القريب لهم بإذن الرحمن إن شاء الله. شكرا لزملائي أعضاء مجلس الإدارة على التنظيم، شكرا لزملائي وزميلاتي أعضاء اللجان على التنظيم الأكثر من رائع. أتمنى لجميع الحضور الاستمتاع في المؤتمر، وأتمنى التوفيق والنجاح لمؤتمرنا، والسلام عليكم ورحمة الله وبركاته.
فلسطين حكاية ألم وأمل. في عمق أراضي فلسطين ازدهرت الوردة الجميلة التي تسمى بزهرة الأمل بين أحضان التراب الجاف، فكانت تلك الوردة الوحيدة التي استطاعت مقاومة جفاف الأرض وصقيع الزمان. تعكس زهرة الأمل معاناة الشعب الفلسطيني، فكما تستمر في النمو والازدهار رغم الصعاب، كذلك يتمسك أهل فلسطين بأملهم في غد أفضل. الأطفال، تلك القلوب النقية التي لا تعرف الكراهية، تحملوا عبء المعاناة بصمت. تراهم يمشون في شوارع البلدة بأعين تنبض بالأمل وتشرق بالحب، ورغم تهالك ملابسهم ورجليهم التي تلوح منها آثار العبور عبر الصخور، لا تفارق ابتسامتهم البريئة الشفاه. وفي محيطهم نساء يحتضنن الأمل بقلوبهن المجروحة، يعملن في صمت على إعادة بناء فلسطين المتهدمة، يقاومن بكل قوتهن وجهدهن ليظل الضوء يشع في هذه الأماكن الظلماء. وكبار السن فهم أعمدة الصمود في هذه الأراضي المنكوبة، يحكون قصصا عن أزمنة كانت بلادهم فيها تتلألأ كنجمة في السماء، وكيف تحولت إلى أرض قاحلة تغمرها الحزن والأسى. أما رجالها فهم العماد القوي الذين يقفون بكل فخر وشموخ، يرفعون رؤوسهم عالية رغم وطأة الصعاب، يحملون في قلوبهم روح الثورة والمقاومة، ويؤمنون بأن الحرية ليست مجرد كلمة، بل هي حق من حقوق كل إنسان، فهم يمثلون نموذجا للعزيمة والصمود. وعليهم يتعين تحفيز الأجيال الجديدة لأن تستمر في مسار النضال من أجل تحقيق العدالة والسلام. وفي مقابل هذه المعاناة الجسيمة، يظل الكيان الصهيوني الغاصب يستمر في استباحة الأراضي وسفك دماء الأبرياء، وتستمر الحروب والصراعات في طغيانها دون أدنى رحمة أو شفقة. ومع كل هذا تتجدد الأماني والأحلام في قلوب شعب فلسطين الحر، يبذلون الغالي والنفيس من أجل بناء مستقبل أفضل، يعيدون لأرضهم البهاء والحياة. في نهاية المطاف يظل الأمل والمقاومة هو السلاح الوحيد الذي يستطيع هؤلاء الناس الاعتماد عليه. إنهم يؤمنون بأن يوما ما ستعود بلادهم إلى ما كانت عليه، وسيعيشون في سلام واستقرار تحت ظلال زهرة الأمل.
اليوم جميعنا مع أخواننا الفلسطينيين، سواء كنا ولا زلنا في هذه القضية الإنسانية. اليوم مع التواصل الاجتماعي أكيد شايفين أن القضية صارت أكثر، خلينا نقول عالمية أكثر، فاللهم أرحم شهدائهم وانصرهم والله يكون في عونهم. والآن نرحب في رئيس المؤتمر الدكتور إياد المقيد، فليتفضل بإلقاء الكلمة.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين نبينا محمد وعلى آله وصحبه أجمعين. ممثل معالي وزير الصحة الدكتور أحمد العوضي، راعي المؤتمر سيد عبد الرحمن الفارس، وكيل وزارة الصحة المساعد للشؤون الإدارية، الزملاء، حضورنا الكرام، بالأصالة عن نفسي ونيابة عن إخواني أعضاء اللجنة العليا المنظمة للمؤتمر، يسرني أن أتقدم إليكم بخالص الشكر والتقدير لمشاركتكم في هذا الحدث، والذي نعتبره شرف لنا ولجمعية أطباء الأسنان الكويتية. يعتبر مؤتمر الكويت 23 لجمعية أطباء الأسنان الكويتية صرحاً وحدثاً علمياً بارزاً على مستوى منطقة الخليج والمنطقة العربية، ويعكس مدى حرص إخوانكم في جمعية أطباء الأسنان الكويتية على أهمية التطوير والتدريب العلمي والعملي، والتي نعتبرها نقطة تحول في اتجاه إعادة بناء ورفع مستوى أطباء الأسنان برؤية علمية وتعليمية، وكذلك خلق جو من التبادل العلمي والترابط بين أطباء الأسنان في دولة الكويت ومختلف الدول، وتحفيزهم للعمل المشترك والسعي إلى كل ما هو جديد في طب الأسنان من أجل مستقبل أفضل. كما يواكب مؤتمرنا حدث استثنائي، وهو بأن لنا آباء وأمهات وأخوان وأخوات وأطفال في فلسطين، وتحديداً في غزة بلد الكرامة والعزة، يعذبون ويقتلون من قبل الكيان الصهيوني الغاشم المغتصب. ولا تحسبن الذين قتلوا في سبيل الله أمواتا بل أحياء عند ربهم يرزقون. صدق الله العظيم. السادة الزملاء، أتقدم بالشكر الجزيل للأطباء المشاركين واللجان والجهات الراعية والداعمة على مشاركتهم الفعالة لما يقدمون من جهد مخلص وعطاء متميز يساعد في إنجاح هذا الحدث العلمي الهام. ونتمنى للجميع المزيد من التقدم والازدهار والاستمرار في العطاء. كما أتمنى للزملاء المشاركين من خارج دولة الكويت طيب الإقامة في بلدهم الثاني الكويت. ختاما نقول: بعلوم طب الأسنان نرتقي وفي الكويت نلتقي. والسلام عليكم ورحمة الله وبركاته.
كل الشكر لكم حضورنا الكريم. أوكي. حضورنا الكريم، مع افتتاح المعرض مع الدكتور محمد دشتي والدكتور إياد المغيد ووكيل المساعد عبد الرحمن الفارس. تفضلوا.
ياخذ صورة تروح معاهم دكتور.
يلا يلا بس لحظة.
بتنافسنا
مالي ومالك
شوف ده
ماشي، ما انت قول له
قلت له كتير.
هي طبعا هون كل شركه في لها في سيتنجز خاصه فيها، على اساس انه الدكتور ما يحاذي بموضوع انه بده يعمل سيتنجز خاصه لكل شركه، لا هون كل شركه في لها سيتنجز فهو مباشره بحط السيتنجز تبعه وبيبدا يشتغل.
هو بس كمان هو في بعض الفايل بتاع السبلاي كمان لو اشتغل فايل تاني من السبلاي اشتغل عليه.
جاهز احمد؟ صورة
يا عم نافسني.
صورة
يا نسيني وانت على بالي. طلع صوتي
تفضل عليك الدكتور
شوف ورا، انا حمار
ورا شوية انت ورا شوية.
أجهزة هناك أجهزة إصلاحك وأجهزة زراعة.
عشان الناس عماله تخبط فيها مش الظهري
هذا أول ذراع آلي في العالم. أول ذراع آلي في العالم يعقم الأدوات فولي أوتوميتد. يعني الأدوات تنحط من كاسيت، الكاسيت ينفذ من الذراع، يتغسل، يتشيس، يدش الفرن، والروبوت بعدين يطلع من الناحية الثانية للاستخدام. طبعا هو يقدر يسوي 6 كاسيتات في الساعة، بس هذا طبعا الجيل الأول. الجيل الثاني راح يزيد على الكاسيتات. فطبعا فنيين وفنيات التعبير يرتبون الأدوات ويدخلونها بس من ناحية. الروبوت يتكفل في الغسيل والتنظيف والتجهيز والتعقيم داخل الفرن مال التعقيم، واخذ المنتج النهائي الى الناحيه الثانيه على اساس يتم استخدامه. فطبعا بالعمليات الواحد ساعات ما يلاقي الست بالتعقيم مطوله شوي. زين هذا ممكن يشتغل 24 ساعه ويعقم الادوات كلها ويوفرها بحيث انه ما يصير عندك نقص بالادوات. ممكن توفر في الادوات. لا تثق فيه ونص. تقدر لا
10 سنين كنا في دبي يمشوا هلا المترو ما في سواق.
ما في سواق.
نعوذ بالله مترو من سواق نزول شوفير. هذا 10 سنين زيرو انسيدنت، صفر حادث. هو الهدف للجهاز يشتغل 24
ساعة. هو يسرع، بس هو في الساعة الواحدة يقدر يعقم 6 كاسيتات. التعقيم يوقف خلينا نقول لما الزام ينتهي. يقلبون زام العصر، بعدين زام بالليل يكونون محدودين الناس. فممكن تجي الصبح انا ادخل شوية الست بالفرن، لان امس كان عندنا حالة طوارئ. فانت ممكن تستخدم الروبوت هذا في المستشفى، في الجامعة، في عيادات الاسنان. هم بعد في روبوت اي شيء ممكن تقطع عليه. فهذا الروبوت يعقم غرفة العمليات بتقنية الأوزون. الأوزون حتى الشق اللي بالطوفة يدش داخله ويعقمه. فطبعا البريفيوس جنريشن او الاجيال السابقه موجوده عندنا في الوزاره اللي هي الالترا فايولت لايت، اللي هم الشموع هذول اللي يحطونهم في غرف العنايه المركزه، تعقم الغرفه قبل ما تجي فيها مريض ثاني، غرف العمليات. هذا موجود في الوزاره حاليا. بس هذا النكست جنريشن الاوزون فعاليته في تعقيم الاسطح، يعني هاي تقدر تستخدمها حق غرفه عمليات، الصيدليه، المختبر، سواء مختبر اسنان، مختبر الدم، استاذ جابر تقدر تعقمه. او يعني التعقيم بالاوزون ممكن نخليه هني يمشي بالليل يعقم المكان كله، وتي تاخذ مسحات ثاني يوم وتشوف اذا هل فعلا معقم ولا لا. وعندنا تقنيات ثلاثيه الابعاد يعني كثير. احنا عندنا اول شركه في الشرق الاوسط تجيب هذا الروبوت، اول شركه في الشرق الاوسط مو بس بالخليج، هم بعد تجيب الروبوت هذا تقنيه حق الاسنان على السرعات.
انا بس مش عارف هو هيعدي منين، بس انا مش عارف.
عندنا حلول يعني متكامله حق المشاكل هذه. اكزاكتلي،
لانه هو غاز يدخل يعقموا فيه. انا بعرف اذا
انت هذول
دكتور في ريحه بالبيت الاوزون
هذول طبعا هم يشتغلون مع سيمنز في المذر بورد، وتقدر انت تكستمايز شنو طريقه التعقيم اللي تبيها. فالسوفت وير مو سوفت وير واحد، المذر بورد مو مذر بورد واحد. تقنيه الاي جي بي اللي هي القاعده هذه اللي تشيل الجهاز اللي فوقها، يقدرون يتحكمون على حسب انت شنو تبي. تبي تعقم غرفه عمليات مثل ما قلنا، مختبر اسنان، صيدليه مثلا، الكوفيد فلور مثلا، جناح الكوفيد ممكن يتعقم. الله يعافيك، فرصه سعيده، فرصه سعيده.
ما قبل خلص معي فكره. خش يمين ولا شمال؟
I think so.
ثواني.
الجهاز لازم يكون جنب الجهاز ويشوفه.
طب انا اعمل ايه؟ ما انا
ما
صورت.
يبقاش في اخر الدنيا تبص حلوه الدهن دي. ارجع الكريم واخذ الحلوه احمد سعد شوف معاك.
الحين ما
كده اوكي. خلي هذا اوكي بس انت طق طقه طويله بس شكرا.
2 3 شغال ها بعدين
multi-specialties. Every one of us have a topic to talk about today. And after each two speakers, we're going to have a question. We're going to throw a question to the audience. You're going to have a prize after that. So if you pay attention to their 10, 15 minutes presentation about their topics, you will get it, you will answer it, you will win. And again, I have senior dental students, which is going to be our colleagues soon. They're going to handle this. They're going to present our doctors. They're going to be the chairperson, and they're going to handle the question and answer and the competition. Please welcome everyone.
Assalamu alaikum. Good evening, everyone. Thank you for preparing yourself to join our seminar. This is the first day of KDA. In the morning, we had informative lectures by amazing doctors. However, this evening will be a bit different, nevertheless enlightening. Our first subject is titled Epicosurgery versus Retreat. As a dentist, the first thing you do when you look at a radiograph of endo-treated tooth, you would ask yourself, did the previous doctor achieve the correct working link? Is there a missed canal? Was a rubber dam used during the treatment of the tooth? If not, could the root canal still be infected? Then you would wonder if a treatment is required or an epicectomy is the treatment of choice. Dr. Mohammed Al-Fatam will further discuss the subject with us. Dr. Al-Fatam received his Bachelor of Dental Surgery from Liverpool University in 2007. He worked in Kuwait and completed his MFD in RCSI in 2009, completed his specialist training in endodontics at Cardiff University, where he received his master's in clinical dentistry with Murat, and membership in endodontics in RCSE in 2013. In addition, he received his FDS in RCSE in 2020. Dr. Fatam has a long clinical experience. He's an author and a speaker at national and international level. Please welcome him.
Assalamu alaikum everyone. So today starting the session. First of all, I'm very thankful for the invitation and for this KDA conference. It's always a pleasure being here. And I'm very proud to be in association with the Kuwait University Dental Students session. I believe it's the first time it's been happening. So let me go straight into the subject. Basically, we have like a small presentation, mainly a discussion. Feel free to ask any questions, interrupt me at any point. It's not like a formal presentation. So I'll just go straight into the slide, reasons for root canal treatment failure. Basically, the topic is apical surgery versus non-surgical retreatment, which means a treatment has been done in the first place, an initial treatment. So why it fails? This is from a theory point of view, from a literature point of view. Intraradicular infection is one cause. Extraradicular infection, foreign body reaction, tooth cysts, cholesterol crystals, and there is also something called scar tissue, but we don't mention it because it's not really a true failure. It can be missed as a failure. So this is the list of 5 possible in-theory failures of root canal treatment. The first one, intraradicular infection, is probably the only way to solve it is by doing a non-surgical root canal retreatment. The other in the list, in theory, can only be managed by apical surgery, but in clinical application, this is not possible because you will not know what's the cause of the failure. Moving on, what happens to essences and accessory canals after canal shaping and also obturation or filling? Approximately half the debris made during instrumentation remain in the canal system. This is a slide from a study where they show in the green is where the untouched surfaces. So there will always be some debris or surfaces in the root canal that will not be cleaned or shaped properly. So there is clean or disinfect completely. So what's the treatment options? We know failure is bound to happen. It will happen. Studies say it's about from 80% to 95% success rate or survival, whatever you want to call it. The treatment options is non-surgical retreatment, apical surgery. That's the two treatment modalities that is in our presentation today. Reimplantation. Some people call it immediate reimplantation, is another option, which is basically extracting the tooth, doing an apical surgery outside the mouth and replacing it back. Sounds drastic, I know. It's very difficult to convince a patient to do it, but it's a treatment option. Transplantation, which is the same, but placing the tooth in a different site. Extraction with or without replacement. Indications for non-surgical root canal retreatment. Improving the quality of the previous root canal treatment. Probably this is the most important indication. So before you decide to do a retreatment, can you improve on the existing treatment? And when I say treatment, I don't mean root filling. The whole concept of retreatment, trying to get more information other than the radiograph or the CBCT that you have. Having a bad root filling inside on an X-ray does not mean a bad treatment. We know root canal treatment is all about disinfection, so we have to ask the questions, you have to find out, investigate with the patient or from the history, whether, for example, a rubber dam been used in the previous treatment, whether it's been done by a specialist, if you have any information about the previous treatment. Restorability, again, there is no point in doing a retreatment for a tooth that is not restorable, and believe me, it happens more often than you think. A lot of people try to restore a tooth, then they try to treat or retreat a tooth, and then it's not restorable. Motivated patients, which is probably one of the most challenging things, because trying to convince a patient to do something again that